Okay, it's on my clock, it's nearly 1 o'clock. So in a few seconds, we will start this first ISAC COVID-19 symposium. Um, so let me put this on. I would like to welcome everyone to this symposium, which is a first for ISAC doing a symposium online. We were trying to do an around the world in 80 minutes on COVID-19. And this story is written by ISAC Academy, I would say, whereby I'm hinting to the fact that this is also the first ISAC Academy symposium. Just as a quick introduction to it, ISIC, and I will keep it short, it was founded in 1961, which due to personal bias, I find the most special year there is. ISAC is a federation of affiliated member societies. We presently have about 88 national and local societies with more than 50,000 individual members who are joined within ISIC. So we are very happy that we were able to reach out to everyone today. And during the symposium, there should be around 776 people who had registered. Some might still be uploading, some might be sharing computers, we don't know, but we are very happy to do this. This is just a quick picture of the ISAC executive committees as they are standing right now. And I am allowed to start the symposium as I am happy to serve as a current president to our society. And I'm very glad for all our members, many of which you will see back and hear back as speakers in today's symposium. Once just a quick coverage and a map of where ISIC is represented. And as many of you might know, Pure became a part of the brand of ISIC. So with ISIC and the Pure, we now cover quite a big part of the globe. Even so, for all the Africans there from the gray zones, please, if you have a society, we welcome to join. As I already mentioned, we decided at the beginning of this year that we need to do more for our membership. So we founded ISAC Academy, and this is the first of the symposia and the meetings. And oops, why is it not going further? I would like to thank Serhat, Unal, and Matthew Dryden, who are not only the driving force behind ISSC Academy, but also the driving force and moderator of today's webinar. And in that, I also have to thank Delta Medical Communications, who help us to realize the seminar and to actually our partner within the ISAC Academy. The program you have seen, so I'll forget about it quickly. Instead of that, I wanted to go and open up with a few numbers from the Netherlands, so a little bit early on, before Benedetta's talk. But as you know, we have more than 60 million cases around the world at the present time, with 1.4 million deaths. If I look to the Netherlands, which is a small country of 18 million people, we have 500,000 cases, a little bit more than 9,000 cases, so a case fatality of 1.8%. If you look into the mortality, and I wanted to bring this paper, which was just recently published about COVID mortality and the different nations. So this is really a kind of a different disease hitting those countries that have experienced a higher life expectancies, even so the curve in those countries mostly flattened over the last years. so thereby mainly hitting developed and aging societies and those living above the 25 parallel latitude, which is obviously for the Netherlands also the case. So we see that in the countries with a higher GDP and chronic disease level, like chronic vascular disease and cancer, we see more cases and then it's more mortality. And it's also obviously associated with metabolic risk factors such as inactive lifestyle or obesitas. And for all those of you lucky enough to live at a higher temperature and higher UV levels, this is associated with lower death rates. And maybe these factors might be even more important than strategies chosen by others in the cases we see around the globe. I want to show you for all the Europeans this Corona status, which is a really like wonderful animation that was made about how coronavirus spread over time from January the 29th until today. And for those in Europe and others interested, please copy the link above. Unfortunately, it doesn't work when I need to change. So instead of what I did, I'll just show you a few pictures out of this movie, namely March 16, where you can see that we already had quite a few cases in Italy and in parts of Spain. Then it moved fast in April 16, 2 months, months later. We see that Spain is by now all more or less into the red color, but it also reached the northern countries and the UK that became quite colored. In then it we reached some highs in May. It was already returning. In June, it was countries like Sweden who had before very few cases and were praised for that. But now, while the rest of Europe certainly had lower rates, they started. In September, you can see it's coming back after the summer vacation. And by now in November, we are in the midst of the second wave in Europe, with very intense numbers, as you can see from those pictures. There's very nice overviews from the two showing all the different trends for different countries. Just wanted to point out, yeah, there are a few low ones like Estonia, Norway, Finland, and others. And then among the highest numbers we see per 100,000 inhabitants, unfortunately, is also the Netherlands with 651. This was on the 5th of October. Yesterday, on the 24th of November, it was about half the numbers, or 22.9 per day, or if you see it over the 14 days, 320. So we are on our way down, but it's a very slow release. Even in a small country like the Netherlands, we see very different distribution between the provinces we have. So we see very different numbers, even in a small country like the Netherlands. And if you look at the cases as of August 31st, you can see that the second wave, this is cases per day, so we went up to over 10,000 cases a day. And yesterday we were at around 3,500 cases a day. So it's a slow moving, I would say, and slow decreasing second wave for the Netherlands. If you look at those who unfortunately die from COVID, then you can see that, and as you all know, it's a disease of the elderly, most certainly in this country. So it's the people above 80, and then a higher proportion of men, at least until you reach the 90-year-old ones, and that probably has to do with the fact that there are far fewer men left. But until then, it's mainly men, and it's mainly in the high age group that die from COVID. What we do in this country, we show everyone. We have an app, and in the app we can show everyone what is the present number of the daily number per 100,000 inhabitants tested, like down here. or we had 3,979 actually yesterday, or 12% of all those people who came to our testing streets, as we call it, the test locations. And you can see that the number tested within the last week in my country was 251,000. And as I said, we have about 17 million inhabitants, and the positive number of cases in the week was 30,000, with 12% being positive. In the beginning of October, when the second wave really hit in my country, that was up to 21%. So last few slides, the questions during the first wave were mainly what type of PPE to use, especially with regard to masks. So long discussions between medical masks versus respirators, the importance of asymptomatic transmission and the role of aerosols in the transmission. We clearly had lots of discussion about the role of school children, which, by the way, and the second wave schools were completely open all of the time. There was far more discussion in these countries about comparison of lockdowns and should we have a lockdown and how far should it reach? And we certainly saw the most problems in long-term care facilities, also with regard to implementation of infection control. Now during the second wave, which I find is very different, it's far less high, but way longer. So we could say that the area under the curve for the number of cases will be far more than the first one. We see far more cases with a lower death rate in general. What we also experience is, while the first wave, it was mainly COVID, now it's no more reduction in standard or normal care. It's extremely busy in our hospitals, which might explain why we see more cases among patients and healthcare workers from unexpected cases of COVID in our, what we call the green part of the non-COVID areas. But it has to do with how busy our hospitals are. We now see that maybe the Dutch were the last standing effort of not using universal masking, but due to the pressure of union and lay people, that might change or will change, and already did for many areas. And we see a new trouble, and that's my last slide I want to finish with, which I now see as the highest risk in my country, is all the problems around ventilation support in the form of this nasal kind of ventilation, where you give oxygen for up to 60 liters a minute via those nasal tubes. And we see infections among healthcare workers, despite the use of protection and PPE, and including the mask, where we believe this clearly is an indication for FFP. And we see, in unexpected cases, we see transmission to roommates, which we do not see in the absence of this so-called aerosol generating procedures. And by that, I quickly went through my own talk. I would like to thank already now all the speakers who took the extra effort. Some of them will be, as mentioned before, recorded, as it's due to the time differences. And I would like to hand over to Serhat and Matthew, who will not introduce only the next speaker, Benedetta, which I'm very thankful for being in here, because I know how busy you are, but also will lead us through the whole seminar tonight. Thank you today. Thank you very much. And I hope that you will enjoy the rest of the 80+ minutes around the globe.
Yes, Matthew.
Thank you very much, Andreas. It's Matthew Dryden here. I'm speaking from Winchester in the United Kingdom. We're now going to move on to the rest of the session. And the next speaker is Benedetta Allegranzi, who is the technical lead for infection prevention and control in the WHO. So over to you, Benedetta. Thank you.
Thank you very much, Matthew. Thanks a lot, Andreas, as well. First of all, can anyone confirm that my presentation can be seen?
Yes.
Okay.
Yes, we can see it and we can see you.
Okay, that's great. So first of all, good morning, afternoon and evening, everyone around the world joining this very nice ISAC webinar. I also would like to say hello to all women today, given that, as you know, it's the International Day to prevent violence against women. It's not really the topic of today, but we know that this has been a problem that has increased over time during this pandemic. So I wanted to remind everyone about the day of today and the reason why I'm also wearing orange color. And then, as I said, wanted to really thank ISAC for organizing this symposium, but also for all the activities you do around the world to continue to advance both evidence and also involvement of our stakeholders, users around the world on many topics. So I would like to clarify that the intention of my presentation is really not to talk about COVID in general or to provide figures that Andreas has already provided in part. I know that there will be many speakers today that have international or national view. I would like to focus on my own expertise and area of work, which is infection prevention and control, and use this opportunity to explain, one, how WHO operates in the context of this pandemic, and also put on the table a couple of topics for reflection. Some of these topics have already been mentioned by Andreas. So my presentation will cover the aspect of WHO guidance on infection prevention and control, just to give you some examples of what has been done and especially how it has been done, and then really reflect on a couple of issues that have emerged over time in this pandemic. The problem that we face with the new virus, which is paralyzing the entire globe, for which we have limited evidence and for which, however, we have to very rapidly and very effectively develop advice and provide advice to the entire world and what this entails. And finally, really move to the area of research, in particular for infection prevention and control. So first of all, like other groups in WHO and other organizations and at the national level, many of you have been in this position over the last 10 months, really needing to develop guidance for different sectors and in different fields. Of course, clinical management guidelines have been paramount. Surveillance guidance have been very important, but infection prevention and control, I'm sure you will acknowledge that has been also super necessary to be developed very fast. And for this, we are very grateful to many experts who have supported us in a very active IPC guidance development group. Andreas has served until recently as the chair of this group, and other colleagues in this webinar are also involved. It's only because of them and thanks to them that we have been able to issue so far 12 technical guidance documents related to IPC topics and updated most of them. And I would like to highlight how challenging this is so fast while trying to really assess all the available evidence and also trying to ensure quality to these documents using an emergency process, but still building upon the great approach for evidence to guidance development. So then the next point is really, how do you translate this guidance in action? How do you achieve that people, countries adapt and adopt this guidance and makes it happen at where it needs to be, either in the community or at the point of care. This is equally challenging. These days, we see the issue of infodemic, for instance. So translating technical guidance in plain language and also convincing others to uptake this guidance is really difficult. So we work through our regional offices, our country offices, and our guidance is also taken thanks to the support of many organizations. We work closely, in particular CDC, ECDC, Infection Control Africa Network, African CDC, UNICEF, GORN, many others, ISAC as well. We also provide countries with very specific support upon request, and we develop a number of risk communication materials and trainings to support dissemination of guidance. And in fact, you can certainly access and know about a number of videos demonstrating, for instance, the appropriate use of masks or how to make your own fabric masks according to the specifications that WHO recommends. And a number of other types of communications material to be used, for instance, in social media, which is obviously very important nowadays, distinguishing the different types of audiences, for instance, regarding masks between health workers and the public. Regarding training, we invested a lot in a number of online trainings which are delivered through our platform, which is called Open WHO. I'm happy to say that there are many different courses that we have been able to develop, and we have had more than 800,000 enrollments and participants in our courses during the COVID outbreak. So, and these courses are also available not only in English, but other 20 languages that are displayed on my slide. And you can see that participation is from all regions, with some regions such as the Americas or Southeast Asia that are more represented, and in many languages, as I said. So first reflection is that based on what I explained so far, clearly infection prevention and control has got a lot of attention during this period. And for instance, there has been a lot of more training around the world, both active, but also remotely online training that has been uptaken by health professionals, but not only. Also, for instance, our audience is very much represented by students, for instance. So, moving to one of the points I wanted to make is the difficulties to develop guidance in absence of evidence or having limited evidence. So I just would like to bring you two examples here. And of course, I have very limited time, but you can find further information, an update of the evidence in the new mask guidance document, which will be issued by WHO tomorrow or Friday. So in two main areas, which are really paramount, everybody talks about it, which is masking in healthcare facilities and in the community, the evidence we have is really limited. So as you may know, WHO has recommended use of masks in the community in a number of, high number of situations that have been promoted and recommended in the guidance document that was issued in early June. And of course, the recommendation is specific for the community according to specific risk approaches, and we will talk about this in a second. But for healthcare facilities, it is now recommended to use universal masking in all healthcare facilities, in particular where there is a community or cluster transmission of the SARS-CoV-2 virus. We came up with the majority of our expert group recommending this approach, despite of the fact that the real evidence for using masks by everyone in a healthcare facility, regardless of providing care to COVID patients, is something that is based on only 2 studies. Studies that demonstrate that implementation of a universal masking policy in hospital systems was associated with decreased risk of healthcare-acquired infection. These studies also have many limitations. They are before-after studies, there is no control group, and there is no control for other infection control measures, etc., etc. So this is one example of a recommendation that is widespread, as you know, but it's based only on 2 studies and on expert consensus. Similarly, the use of masks in the community, which is a controversial issue that Andreas has mentioned. Again, WHO, as I was saying before, has a risk-based approach, and now in the new guidance also really applies this risk-based approach to many more situations, basically recommending use of masks indoor or in outdoor settings when the physical distancing cannot be maintained, and also considering the aspect of ventilation when it's indoor. So when ventilation is inadequate or not properly maintained, the mask should be worn regardless of the physical distancing. Again, it was very difficult to get to these recommendations because the evidence is very limited. And I brought you here 3 main references, and in the guidance document, you will be able to find much more evidence. But basically, you know, last week there was an updated Cochrane review by Jefferson and colleagues published on mask use, showing that wearing a mask doesn't make a significant difference. There is another review by Hsueh et al., which is a living review in the Annals of Internal Medicine, which as well provides controversial and conflicting evidence on this topic. And then I cite the very famous recent RCT from Denmark, which showed no significant risk reduction to acquire COVID when wearing a mask for protection. And it's the first really COVID study and randomized control trial. We know that there are 18 that we know so far, published and unpublished ecologic studies which show a certain level of effect in reducing COVID-19 infection incidence in different countries following the implementation of universal masking in the community. But we also know that these studies have major limitations in, again, lacking information about the actual exposure risk among the included individuals. They lack information about the actual compliance with mask wearing, and they don't control for other interventions that are clearly implemented in the population together with masking. So again, we are obliged to say that while we have a recommendation clearly recommending masking in the general public in specific situations, but quite many of these situations, while we recommend this, the evidence is only limited and inconsistent at this point in time for masking of healthy people in the community to prevent infection with SARS-CoV-2 in particular, but also with other respiratory viruses. And in face of this limited evidence and the recommendations, you can see on this slide a very recent update of the map related to two regions, Europe and the Americas, showing that they have very different approaches. In Europe, the approach that prevails is a risk-based approach, limiting the mandatory recommendation of using masks in specific situations in most countries. This is in 33 countries, whereas 19 countries have recommended widespread universal masking in the general population. The reverse is for the Americas, where most countries have the latter, the universal masking, and only a very minority of countries either don't have any guidance or have a risk-based approach. So before I conclude, the last point I would like to make. WHO has worked over the last 9 months with a large group of experts to develop recommendations on what are the areas, the priority areas for research in many areas. In particular, I'm talking about infection prevention and control. And here you have publication, the R&D blueprint for COVID-19 that was published in February, highlighting that areas of priority were, first of all, understanding the effectiveness of a number of non-pharmaceutical interventions to limit secondary transmission in healthcare and in community settings. The second objective was really health worker protections through assessing the effectiveness of PPE and other aspects. And then another priority was modes of transmission, and in particular, understanding the role of the environment. More recently, in July, we reconsulted the same experts and gathered from them advice on, again, the priorities for IPC research, which are displayed in this slide. I don't have time to go into the details, but I want to highlight that it was pointed out that we still have insufficient information on modes of transmission, and in particular on the role of airborne transmission and its implications for preventive measures, in particular related to the need for better ventilation or the distancing or the type of masks to be used. Also, it was highlighted that we still have insufficient evidence on the role of fomites and the contaminated environments. And one element which I want to highlight, and it refers to my first slide when I was saying we have identified priorities for research which we would have never thought about in the past. Or I correct myself, we discussed a lot about this, but only in context of low-income countries where you don't have the provision of, for instance, gloves or masks. And I'm referring to the fact that there are tens of research groups nowadays who are actively investigating about methods to decontaminate PPE, single-use PPE, such as respirators, such as gloves, such as surgical masks. So it's an innovative area, which is very interesting, but it's really amazing for me to know that This area of research had no interest until recently, although we discussed about it many times in the context of the African Ebola outbreaks. And now there is mounting evidence that we also facilitated, that, for instance, respirators can be decontaminated and reused following decontamination with methylene blue or with dry heat or other methods. And we discussed nowadays currently about decontaminating gloves with using alcohol-based hand rubs, for instance, which is quite unfortunately a widespread habit, but is also studied from the research point of view. And so far, there is no evidence about the possibility of doing this safely. So this is my last slide, reminding that WHO is conducting research and funding research in the areas that you see on the screen, which basically, as I said, reflect the priorities that were identified by experts in the context of the R&D blueprint. And with this, I would like to thank you very much for giving me the opportunity to reflect and discuss about these topics. Thank you.
Benedetta, thank you very much for that succinct overview from the WHO. That's really helpful. We've got a lot of delegates who are signed in, and can I just remind everybody who's listening to the symposium that we would welcome your questions and comments. Please put them in the Q&A tab down the bottom, the Q&A Zoom tab. We may not be able to answer them immediately, but we will certainly pass them on to the speakers and get a response to you in due course. We're now going to move on swiftly to the national and regional presentations from around the world. And the first speaker, and this is, I think, a pre-recorded session, is Professor Po-Ren Hsueh, who's Professor of Internal Medicine at the National Taiwan University. And he's going to be talking about COVID in Taiwan.
Good afternoon, ladies and gentlemen. I'm Po-Ren Hsueh from National Taiwan University Hospital, Taipei, Taiwan. I am an infectious disease specialist, a clinical microbiologist, and also the immediate part of the ISAC, president of ISAC. In the previous 20 minutes, I think the professor of has presented to you the global status of the COVID-19. Now, I am going to share with you about the COVID-19 status in Taiwan. So, as of November 22, the SARS-CoV has infected more than 58 million people from 191 countries and caused more than 1 million deaths globally. The case mortality rate is around 2.4. In Taiwan, Taiwan is located in the northeastern part of Asia. The main island of Taiwan has an area about 36,000 square kilometers, slightly bigger than the Maryland and around half of the size of the Scotland. In 2020, there are around 23.8 million inhabitants in Taiwan. Importantly, Taiwan is located approximately 100 miles off the coast of the southeastern China. Many people frequently travel between Taiwan and China. Particularly in this January, many Taiwanese return home from China for the Lunar New Year, just when the SARS-CoV-2 virus was rapidly spreading from Wuhan city to other parts of China. Therefore, it was predicted that Taiwan will have the second highest number of confirmed COVID cases. However, if we back to 2003, the year of SARS pandemic, Taiwan was ranked the third of the case number of SARS in 2003, next to China and Hong Kong. So previous experience from the SARS outbreak in 2003 and also H1N1 outbreak in 2009 have helped the Taiwanese government to effectively improve the strategies for normal pandemic preparedness and to establish a public health response mechanism. Obviously, the top 5 countries suffering most seriously from COVID-19 are USA, India, Brazil, Russia, and France. In this year, had quite a few SARS experiences in 2003. This slide shows you the epidemic curve of confirmed COVID-19 cases in Taiwan by week. As of November 22, about 242,000 people in Taiwan had been tested for SARS-CoV-2 virus, of whom and about 617 were confirmed positive, with an incidence rate of 25.9 per 1 million people in Taiwan. Of the 617 patients with COVID-19, 55, around 9%, acquired the infection via the community transmission, and 7 died, representing a case mortality rate of only 1.1% in Taiwan. Importantly, there are no locally transmitted cases in Taiwan for more than 7 months. How Taiwan can keep the COVID-19 at bay? Actually, on January 20, just 1 day before the first confirmed case of COVID-19 in Taiwan and 1 month after the first case of the COVID-19 case in Wuhan, the Central Epidemic Command Center, so-called the CECC, was established to coordinate the inter-ministerial responses. During the early stage of the pandemic, press conferences by the CECC were conducted at least once a day to present the timely information on the extent of the spread of COVID-19 in Taiwan and announce the updated policy and the measures. So this slide is just one of the series of slides recording the daily and important events by Taiwan citizens during this pandemic. Taiwanese authorities, like those from most other countries, responded to this pandemic in several ways, including increasing air and sea border control and the travel restrictions, including those for medical staff. Community-wide use of the facial mask, observing hand hygiene practice, and maintenance of social distance, avoiding crowded areas, active identification of post cases, and the quarantine of suspected cases and the close contact. Establishment of the class suspended and the school closed strategies. Rapid set-up of shelter hospitals. In Taiwan, the city lockdown did not happen. In addition, Taiwanese authorities prohibited the exportation of surgical masks and began manufacturers' name in order to avoid the shortage in the early time. The absence of the locally transmitted case since April 12 in 2020 has allowed the health authority to begin the gradual loosening of the epidemic prevention measure to allow the public to engage in some normal activity, so-called the epidemic new life movement. All citizens could feel safe to shop and dine at any store and restaurant if the necessary epidemic control requirements were met. For example, social distance, personal hygiene, protective equipment. For example, mask wearing and body temperature check and hand washing, cleaning agent at the entrance of the venue. So this is the very common the measures, infection control measures in Taiwan and also I think in other countries. This slide shows you the main infection control and the border control measures implanted and the number of imported and the domestic cases since January to September in Taiwan. Although we faced the 3 main events, including the Diamond Princess the cruise ship in January, Taiwanese students returned from the Europe and the US in March, and also the Taiwanese naval the fleet in April. And we had a lot of cases during the event. with picking the case number of COVID-19. So, however, because the so-called advanced deployment strategy in the deployment strategies, so no local transmitted case was found. But unfortunately, every day in recent 3 months, there were still few people, including students, workers, or businessmen, returned back to Taiwan from different countries were confirmed with COVID-19. Let's now show you the data from Taiwan Tourism Bureau. There was actually a 75% decline in the number of the inbound visitors, with around 5.1 million in this January to 1.3 million in this September. So the number of the visitors from China in this January was around 465,000, and the number of decreased to only 12,000 in this September. So the inbound visitors decreasing, and also from other countries and also from China. In addition, all the visitors entering Taiwan should follow some regulations. For all non-business travelers since December 1st, 2020, a certificate of negative RT-PCR test taken within 3 days of arrival should be provided. After entry, for asymptomatic people, home and hotel quarantine for 14 days, followed by self-health management for 7 days are required. And for symptomatic people, should admit group quarantine or facility and receive the RT-PCR test. And for the business travelers, a shorter 5 days, not 14 days, 5-day home or hotel quarantine for visitors from low-risk country and 7 days for travel coming from the high-risk country. But a self-paid RT-PCR test should be performed before the 6th of the home or hotel quarantine. But a 14 days self-health management after the negative RT-PCR result is still necessary. With about the border control strategies, as of November 22 in this year, the 572 imported cases of COVID-19 in Taiwan were mostly coming from the USA, UK, Philippines, Indonesia, France, and other European countries, and the only 11 from China. As for the 55 domestic cases, most were family members, friends, and other contact cases, in fact, direct from the imported cases. And only 9 were related to healthcare facilities, including 5 healthcare workers. So the limited the healthcare spreading of the COVID-19 in Taiwan. Considering the low risk of the community transmission in Taiwan, our CDC starts to loosen some epidemic control measurements. On April 12, the regular season of Chinese Professional Baseball League, so-called the CPBL, was launched without a spectator, which was the only such activity scheduled everywhere worldwide during the COVID-19 pandemic. And since the May 8th, each CPBL regular season game can be attended by maximum of 1,000 baseball fans. Also in Taiwan, we can enjoy the opera and also the famous movie festival in Taiwan in this November and December. Last but not the least, Taiwan CECC has also been seeking front runner from the Pfizer, from the Oxford AZ, and the Moderna, the vaccine, and the budget has been set aside for the procurement of the COVID-19 shots through the COVAX. Recently, Taiwan authorities said that Taiwan will begin the COVID-19 vaccination as early as the first quarter of 2021, and also announced the priority list of COVID-19 vaccination program. Most importantly, we have the three locally developed and promising vaccines, and the clinical trials are ongoing. To sum up my talk, the Taiwanese model for combating COVID-19 seems successful, and you can obtain more information from literature and the Taiwan CDC website as well. I think universal masking, hand hygiene, social distancing, and effective border control are the key elements for control second or third wave of the COVID-19. Thank you very much for your kind attention.
Thank you very much, Professor Hsueh. A remarkable success story from Taiwan. Thank you very much. We're now moving on to Japan, and the next speaker is Professor Kazuhiro Tadeda, who's Professor of Microbiology and Infectious Diseases at Toho University in Tokyo. And he's going to be talking about Japan's testing strategy.
My name is Kazuhiro Tadeda from Toho University, Tokyo, Japan. It's a great honor for me to present our data in the webinar. Japan's testing strategy, what we learned, what we need now. This is the first page of the newspaper of the South China Morning Post, January 1st, that we knew that outbreak of unknown etiology of pneumonia, Wuhan in China. After that, spreading of this virus, February 14, the number of cases 64,000 cases. Death is around 1,300 cases. But at that time, most of them is in China. But unfortunately, the map of COVID-19 is drastically changed. The November 21st is, as you can see here, US, Brazil, India, and Europe is densely infected with this virus. More than 56 million cases reported, and 1.4 million case deaths, still increasing. This is the data of number of daily cases and deaths in the world. As you can see here left, more than 0.6 million cases daily, more than 10,000 cases death daily. Japan situation is going to the difficult. Around 127,000 cases reported. Death is around 2,000, still growing number. We are facing to the first wave, second wave, now third wave. And the interesting point is that the daily death number is lower number in death in the second and the third wave of the pandemic. We don't know why the reason, but maybe that less elderly people infected, treatment strategy, and mutation in virus, but we don't know exactly. Similar phenomenon was reported in the other European countries, such as France and Spain. As you can see here, in the second wave, lower number of deaths were reported. In contrast, second wave, the more deaths were observed in Australia, which is a south hemisphere of globe. So we don't know why, but higher mortality in winter season. We don't know, but we must be very careful in the now going to the winter. Yes, we learned a lot from the cruiser ship named Diamond Princess. The number of the case is more than 700. Many deaths we experienced. In this event, this is the data of confirmed COVID-19 cases by date of onset diamond princesses. As you can see here in blue, passenger was isolated in their rooms. But unfortunately, crew is walking around between the rooms, so that now we knew that the crew transmitted virus for several times. This is interesting data published in the Diamond Princess data. As you can see here, PCR positive 104 cases, no symptom were 43 cases, and moderate is 41, and severe cases 20. As you can see here, 33 cases out of 43 no symptom cases is no change in the no symptom. I mean that 10 cases changed to symptomatic. And also the 17 of 33 cases, I mean that the 52% of the no symptom cases showed abnormal CT finding like gland blast of C here. Yes, we declare the emergency call every 7, but this is just a request and instruction, not order or lockdown, because of to minimize economic impact. This is a change of daily PCR testing number and positive rate. As you can see here, March and April, the beginning of March, the number of testing, PCR testing is around 1,000 daily, very small number. But then after that, it's a growing number. You can see here, positive rate of PCR is higher and higher, and then going down. We had a very difficult situation in performing the PCR testing in Japan. But now change the situation. One of the reasons is the introduction of the new strategy, a novel strategy for SARS coronavirus through mass screening using quantitative antigen testing of saliva. As you can see here left, that this is the data of the PCR positive and PCR negative. As you can see here, PCR positive sample, higher concentration of antigen were detected. In contrast, PCR negative is a lower concentration of the antigens. As you can see here, CT value and antigen concentration, higher CT value, that's mean the lower copy of the number of the virus is a lower concentration of antigens. It's quite nicely correlated with each other. And also that immunochromatographic method became available. As you can see here, the data around 25 picogram per ml of antigen showed positive in the immunochromatographic method. This method is easy to perform, and we can know not only the COVID-19, but also that by using the same sample, influenza, we can know the results so that to differentiate the COVID-19 or influenza. And first, we started from the nasopharyngeal swab. But as we know, it is difficult to, sometimes it's dangerous to take sample. But now that became available, nasal specimen and saliva is available. I think that's a game changer for the outpatient setting. This is an approved method and a specimen for COVID-19 in Japan. As you can see here, PCR testing, we can use nasopharyngeal, nasal, and saliva. And also that we can use that for sensitive antigen detection tests, nasopharyngeal, nasal, the saliva. And also the simple immunochromatographic antigen detection method, we can use nasopharyngeal, nasal. And also the asymptomatic patient, we can use nasopharyngeal saliva for PCR, nasopharyngeal saliva for sensitive antigen detection kit. So it's improved very much. This is the schematic testing results before and after onset of disease published in JAMA. We know that before onset, it became effective. Virus isolation started a couple of days or around a week before onset, and then continue around 1 week after the onset. PCR data is positive. After that, it's a couple of weeks, as you can see here. Interesting point is that virus isolation stopped. Then antibody increase, like here. So maybe that we can know the infectivity by PCR positive, but also the positive antibody testing. That's a sign of the no infectivity. This is the data of culture results of SARS coronavirus 2 and the seroconversion. As you can see here, with culture positive continued by 8 days after the onset of the infection. But after that, it's almost nothing of culture positive cases. As you can see here, around 8 or 9 days after the onset of the disease, the seroconversion occurs. So that again, we can guess the infectivity by the seroconversion of the patients. Okay, this is my summary slide. Diagnose the key factors in twindemic season, I mean the COVID-19 and influenza. I think that the simple, fast, and correct diagnostic for outpatients is very important. In that situation, immunochromatographic method is very useful. One specimen for both COVID-19 and influenza is convenient, so that we can now use the nasal specimen for both COVID-19 and influenza. And the safer sample collection in saliva and nasal became available. Clinical experience, awareness, and differentiation from the symptom of the patients is very important to distinguish between COVID-19 and influenza. All right, thank you very much for your kind attention. Thank you.
Professor Tadeda, thank you very much for that fascinating account of testing in Japan with a lot of very interesting data. We'll move straight on swiftly to the next speaker, who is from Australia, Professor Ben Howden, and he is Director of the Microbiology Diagnostic Unit at Doherty Institute. And he's going to be talking about genomics to track and respond to COVID-19 in Australia.
Thank you for the opportunity to speak. I'm going to discuss the use of genomics to track and respond to COVID-19 in Australia. The SARS-CoV-2 genome, it's an RNA virus that has approximately 30,000 base pairs and encodes 8 genes. I'm not a virologist, but I work at the interface of public health microbiology and public health response. And so we've used genomics in our laboratory to understand the transmission of COVID-19 in Australia, and I'll be discussing some of the results of this work. Here's a list of some of the key activities that we can achieve using genomics, and it's been really fascinating to see the examples of the utility of this viral genomics during the response to the current pandemic. In particular, there's opportunities for development and deployment of molecular diagnostics, and we very rapidly saw early in the outbreak the development of very specific and accurate molecular-based diagnostics for SARS-CoV-2. And the use of genomics has allowed ongoing comparisons of the primers and probes against circulating lineages to make sure that our diagnostics remain first class. One of the key activities has been the use of genomics for understanding transmission of the virus. And this is including local versus global phylogenetics and transmission dynamics, understanding importation versus local transmission of strains, and then identifying clusters and outbreaks, as well as nosocomial transmission, which is particularly where my laboratory has been working and the area that I'll focus on primarily. In addition, there can be really important clinical questions addressed through the use of genomics, such as whether a new positive diagnostic test may represent persistence of infection versus reinfection, and we're getting increasing experience using the genomics in this way. And there's also opportunities over time to look at whether specific viral mutations may be linked to particular disease phenotypes or outcomes. Obviously, there's huge interest in the development of vaccines and the vaccine targets in the virus, and particularly around whether mutations that are emerging in the spike protein may have some impact on vaccine efficacy. And there's obviously a lot of work that's going to go into understanding the emergence and spread of potential mutants that may have some impact on vaccine efficacy. Before I talk about the Australian perspective, just to highlight how comprehensive and enormous the global efforts are in using genomics to understand SARS-CoV-2. On this slide, I've just got a couple of examples here, one of which is from the COG consortium in the UK, which has brought together a large number of partners to do a very comprehensive sequencing within the United Kingdom. And I believe they recently completed their 100,000th SARS-CoV-2 genome. The other example I've got here is from a public database called GISAID, where there's been global sharing, and you can see the representation on the map of the sequences of SARS-CoV-2 from around the world, which has really allowed important insights into virus spread and evolution to be gained through the analysis of this publicly available data that's been shared very rapidly from around the world. And this is a great initiative, really allowing important insights into the virus and how it's behaving. In Australia, we've got a big focus on the use of pathogen genomics in public health, and there's been a recent release of the National Microbial Genomics Framework for the country. And much of the activities in the public health genomics space are underpinned by an organisation called the Communicable Diseases Genomics Network. And on the map on the right here, you can see the laboratories that are part of this network, and these represent the key public health laboratories within each of the states and territories of Australia, as well as New Zealand. There's been significant investment from the Medical Research Future Fund in Australia into tracking COVID-19 using genomics, as well as other activities in the public health microbial genomics space. One of the major initiatives of the CDGN and its key partners is the development of AusTracker, which is a national platform for the integration, analysis, and sharing of microbial genomic data at the public health interface. And this platform has been deployed to address the COVID response within Australia, such that data can be shared around the country in a confidential and secure way to get really key and rapid insights into the spread of the virus within the country. In Australia, this is the epidemic curve of COVID-19, and you can see there's two major waves of infection, although the numbers overall are relatively low compared to many other regions of the world, with just under 30,000 cases at the time that this plot was generated. So just focusing on Victoria now, which is the jurisdiction which I work in and for which our public health laboratory is the pathogen genomic sequencing laboratory for the state. We have a population of just over 6 million people in Victoria, and we've had a long-term investment in public health pathogen genomics. However, this has primarily been focused on bacterial genomics. And early in 2020, we had to pivot to focus on viral genomics. We rapidly implemented the tiled amplicon approach, and then had to develop bioinformatic pipelines from scratch for the analysis of the SARS-CoV-2 genome in consultation with international experts. And we spent a lot of time optimizing genomic clustering and importantly, correlating this with the epidemiological data. This has been no small undertaking. It's been a large team of 6 scientists, 3 bioinformaticians, as well as epidemiologists and medical oversight. We considered what the ideal strategy would be for our jurisdiction and for Australia more broadly, and really decided to aim for complete sequencing of all SARS-CoV-2 cases wherever possible. And this has been a really important part of the response, because we often get questions from public health units or clinicians around specific cases and comparisons of genomes over time. And so having the majority of these available to form a reference for these public health questions has been really critical. And we're now aiming for a 3-day turnaround time for urgent cases, allowing these questions to be answered as soon as possible. So this is the epidemic curve of SARS-CoV-2 cases in Victoria, and you can see that the majority of the second wave in Australia was due to a large outbreak in Victoria. In green, you can see the proportion of cases that have undergone whole genome sequencing, and this represents the majority of cases over the pandemic to date in our jurisdiction. So I'll initially focus on this first wave, which occurred in early March through to mid-April, and what the genomics insights were from this first wave of infections that we saw in our jurisdiction. So the key message here is, and this graph, this image on the left is showing the genomic clusters. So what we've identified here is unique genomic clusters identified through SARS-CoV-2 genome sequencing and clustering over time. And then the proportion of cases is represented by the size of the circle, and the mode of acquisition is highlighted in the colors, as you can see here. And what we saw in this first wave was a very large number of genomic clusters. And so we were seeing what represented multiple introductions from returned travelers from overseas. And this really represented the global, I have not shown it here, but it really represented the global diversity of SARS-CoV-2 at the time. Interestingly though, most of these clusters were short-lived and essentially dead-end clusters, such that new cases were not being detected within these clusters over time. As I mentioned, we were initially very interested to see whether our genomic clustering correlated well with the epidemiological data. And you can see here, we have epidemiological clusters in the circles, and the genomic clusters are color-coded. And you can see there was very good correlation. And so the genomic clusters were well supported by epidemiological data, providing reassurances that our genomic clustering was accurate, despite the fact that there's very little variability in the SARS-CoV-2 genome to date. The other thing we were able to do with the data was to look at the impact of the public health interventions. That was restrictions in returned travellers, the need for mandatory 14-day quarantine for returned overseas travellers, and then the implementation of a number of staged restrictions. And using phylogenomics, we could look at the genomic interpretation of the reproductive number. And you can see here from early in the pandemic, from late February, early March, the reproductive number was up close to 1.75. And then after the implementation of these restrictions, it was well below 1. And this really supported the effectiveness of these implementations and mapped well to what was being seen with the epidemiological data. So that was what had happened in the first wave. So what's the explanation for this second wave? So what we can see here is a similar figure where we've got the genomic clusters on the left-hand side here by date, with the size of the clusters again, the number of cases again highlighted by the size of the circle. And the key message here is this area up the top, which is all of the cases that occurred after late June of 2020. So by the end of May, almost all genomic clusters had ceased transmission, these early ones here that I mentioned in the previous figure. But from June onwards, there was a rapid explosion of 3 transmission networks, which are identified at the top of the figure here. And each of these was found through epidemiological data to be an introduction from a hotel quarantine breach. And in fact, only 5 or less than 1% of locally acquired cases were outside this transmission network since the end of June. And so this is a very clear example of how the genomic clustering has allowed identification of the source of the second wave of infection and the significant nature of this outbreak. The other thing that we've been using the genomics for, particularly during this second wave where we had up to 700 cases a day being diagnosed in our state, was for looking at healthcare worker and hospital-acquired acquisitions. And this is just one example where we've been able to show that we had very close clustering between 2 healthcare workers in the circles here and 2 linked patients. And what this showed us was that we had, and this is the highlighted here is the area of the phylogenetic tree where these samples sit. And what this allowed us to confirm that a patient exposure was the source of, likely source of these infections in these healthcare workers, and it led to a reconsideration of the PPE approaches and change in PPE practice at this particular institution. And so this is just one small example, but we now have many others where we've been able to either confirm or support a potential healthcare worker or health care setting exposure and infection, as opposed to other cases where we've been able to refute that because the cases cluster in different locations within the phylogenetic tree from the potential source. And so this has been really important for decision making at the clinical interface and has been very valuable for clinicians and infection control practitioners trying to determine the source of infections in their healthcare workers. So just to summarize in some of the key examples of the utility of genomics at the public health interface for SARS-CoV-2, one of the major things that we were able to demonstrate, which I highlighted during the talk, was that there was no ongoing transmission shortly post implementation of restrictions during the first wave of infection. And this was very valuable to the public health unit to know that those public interventions were effective. We were able to identify unlinked cases and clusters within local transmission networks, and particularly this, we were able to identify the source of the second wave. And this was incredibly important so that the public health unit knew that the second wave was due to a new introduction from a breach in hotel quarantine rather than a failure to control the first waves of infections. There's also been examples of transmissions to other jurisdictions within Australia, which have been demonstrated through the use of AusTracker and the comparison of genomics across jurisdictions. And there's also been exclusion of transmission to New Zealand when there was a putative spread from Victoria to New Zealand. As I've said, we've supported suspected healthcare worker acquisitions and excluded inter-facility transmissions. And this has led to changes in infection control protocols. And we've also, although I haven't demonstrated this, we've also been able to look at reinfections versus prolonged infection. And in every case so far, we've found that this is usually prolonged shedding rather than reinfection. And there's also been the ability to provide evidence for secondary transmission where missed cases may explain that source of transmission, which has again been very important for understanding the epidemiology in our jurisdiction. So some of the key lessons then, what we've learned from SARS-CoV-2 genomics, pathogen genomics is providing critical insights to disease spread and response. There's need for, we actually need public health genomic structures in place to permit this rapid response. It wouldn't have been possible to do this without the public health pathogen genomics program already in place. It's very important to have established data governance and sharing processes. And it's more about just sharing the sequence data. It's also the critical metadata. I guess what we've really learned, and this has been critical, is that public health agencies need their information within hours and days, not weeks. And this is an issue for prioritisation when case numbers are high. And when we're having 700 cases a day, there was a real need to strategically prioritise the cases that needed to be sequenced early to inform public health responses. If you're going to use this at the public health interface, consistency in analysis and reporting approaches is critical. And this is very difficult for an emerging pathogen where we're just learning about it as it evolves. But accurate, systematic and consistent reporting is still being developed and deployed across the country and around the world. So I'd just like to thank everyone who's involved in this. There's a huge team within my laboratory, the MG Public Health Lab, as well as the Vidral reference laboratory that we work closely with, and also our funding agencies and our partners at the Department of Health. Thank you very much.
Thank you very much, Professor Howden. That's a very interesting talk. Genomics is clearly a very important tool in establishing some of the questions around complex epidemiology. So our next speaker is Dr. Desh Deepak, who's a consultant respiratory physician from New Delhi, and he's going to be talking to us about his experience around post-COVID-19 infections. Dr. Deepak.
Hello, everyone. It is a pleasure to be sharing my experience with all of you across the globe. And I would like to thank International Society of Antimicrobial Chemotherapy for giving me this opportunity. For initial few minutes, I shall be discussing the scenario of COVID pandemic in India. And then I'll be taking you through a series of case vignettes where we have seen co-infections along with COVID. The first case in India was reported on 30th of January in 2020. And after that, we saw a rapid increase in cases. In fact, lockdown was enforced on 24th of March, which lasted in its full form till 31st of May. And then unlock began in phases from 1st of June. The current situation is that there are more than 8.5 million cases that have occurred in the country. We have had 125,000 deaths till now, and approximately 500,000 cases are still active today in India. If we compare the number of cases in India with the global cases, we see that in India there was a peak in mid of September, after which there was a steady decline for the cumulative figures in the country. However, this is not reflected for individual regions, like in the national capital, Delhi, where we saw that there was a peak in June and there was another peak in mid of September, and now the cases are rising rapidly in this region. These graphs show the deaths that have occurred. If we compare with the global cases, which is shown in the top panel, we see that the number of deaths have remained stable and have fortunately not risen with the graph of the cases, but still there are significant number of cases who are dying. And in spite of our improved understanding of the disease, there are many things which we do not know, and it might be the COVID co-infections which are contributing to these deaths significantly. So now let us look at the co-infections that may occur with the SARS-CoV-2 infection. I would be taking you through a series of cases, and let's see what are the risk factors for co-infections. So we know that there are certain obvious risk factors for patients who are getting hospitalized or are receiving mechanical ventilation as they become more susceptible to nosocomial organisms. Then these are the patients who are mostly receiving steroids and tocilizumab for their role, which has been proven to a certain extent in the management of COVID-19. And these patients also receive broad spectrum antibiotics. We know that there is an immune dysregulation that occurs in COVID, and which may lead to immune exhaustion. And there is an epithelial damage which provides an entry to these organisms. At the beginning of the pandemic, it was expected that the patients with severe COVID-19 would develop superinfections, especially with the nosocomial bacteria and aspergillus. And we were expecting their antimicrobial patterns or the resistance patterns to be similar to what the local trends. And as expected, broad spectrum antimicrobial usage is there, as many times we do not know what are the offending agents. If we look at this study, which shows that the rate of secondary infections is very high, we see that in severe cases, it may range from 5 to 27%, while in those who are admitted to ICUs, the range may be from 13.5 to 44%. But it is extremely high in people who are dying, which is 50 to almost 100%. So that means that these superinfections are contributing in a significant manner to the deaths that are occurring because of COVID. The variation that we are seeing in these figures may be because of the different level of care, the level of infection control practices that are seen, or the way the study was designed. So let us look at the first case, which is that of a 40-year-old male who's a driver by occupation and presented to us with 15 days of illness. He was having a saturation of 88% with uncontrolled blood sugar. So from day 1 to day 8, he was on high flow oxygen with a non-invasive ventilation. His blood sugar needed high doses of insulin for control. In second week of hospitalization, he started recovering with supportive management. And on day 14, he was RT-PCR negative. He was maintaining his oxygen saturation and he was about to be discharged, but then he developed high-grade fever. So although his saturation was 95% on room air, he was having dyspnea and he was having high-grade fever. This discrepancy made us think that we must look at factors beyond COVID. And we evaluated him thoroughly. His procal was 0.09, his ferritin was 940. And eventually we found that he was having a sputum for AFP that was, his sputum was positive for AFP. We started him on first-line anti-tubercular therapy and he fortunately improved and became afebrile in 2 weeks. However, we know that a combination of tuberculosis with COVID-19 can be very serious and can lead to death. If we look at the second case, this was another case of severe COVID-19 who received corticosteroids, remdesivir, and convalescent plasma. He showed improvement, but then there was worsening. His bronchoalveolar lavage showed septate hyphae and it had a raised galactomannan. We know now that COVID-associated pulmonary aspergillosis is becoming a well-known entity. The diagnostic criteria currently used are similar to influenza-associated pulmonary aspergillosis, for which require an infiltrate, raised galactomannan either in serum or in bronchoalveolar lavage. If we are able to culture the fungus in the bronchoalveolar lavage or if there is a cavitary lesion. Kappa is associated with corticosteroid use and has a significant 30-day mortality. Mortality tends to increase by 1.41 for every point of raise in galactomannan in bowel. Another interesting thing that is seen with kappa is that Aspergillus fumigatus itself leads to increased IL-6 production. And it may be contributing to the high level of IL-6 in COVID patients. So use of tocilizumab in such a patients can lead to worsening of kappa. To circumvent this, we may need to measure serum galactomannan or we may need to give antifungal prophylaxis. But we know that with surety things are not known, either for diagnosis of kappa or for prophylaxis and treatment, and in fact, even about immunology or host factors. So as has been very presented in this paper. My next case is about a 64-year-old gentleman who needed mechanical ventilation along with tocilizumab for a raised IL-6. He showed improvement initially, but then he worsened and developed MODS. His blood culture grew vancomycin-resistant enterococcus, for which he was treated with daptomycin, and his central venous line was removed, which was considered to be the offending agent. He improved on day 22. However, on the day 30th, he started having loose and bloody stools. His total leukocytic counts began to decrease and were 410 per millimeter cube on day 36. A bone marrow was performed which showed cellular marrow with increased RE activity, and it was suspected that it was either a drug or a virus which was causing the complication. His PCR for CMV was 13,600. He was started on ganciclovir. Unfortunately, he succumbed to his illness on day 41. CMV and COVID has again a very interesting correlation. It has been seen that IL-6 can cause MIEP activation that leads to CMV to enter into a lytic phase. So on one hand, tocilizumab would abrogate the immune activity of IL-6, but leads to increased IL-6, which by another pathway can activate CMV to enter into a lytic phase. So this is a scenario where one viral infection is making reactivation of cytomegalovirus. We know that cytomegalovirus co-infection has been reported in few other case reports, mostly involving gastrointestinal. So the next case is about a 50-year-old gentleman who had a moderate COVID. He received steroids, tocilizumab, did well, was discharged, but then came back 1 week after recovering with a high-grade fever. He had an interesting history that he was having nodulopapular lesions on his trunk, which during this phase of fever started to increase and involved his face. We evaluated him and did a biopsy of skin lesions from trunk and face and did a bone marrow aspirate. And all of them showed a histoplasma with granulomatous reaction. His urinary antigen for histoplasma was positive. The patient responded to liposomal lymphotransfusion B. So here, this was a case where an existing cutaneous histoplasmosis was flared up because of the disease associated with COVID. And we know that there has been another case report of histoplasmosis, but that was in a patient with HIV/AIDS. Our patient did not have an HIV. My last case is about a patient who received steroids and tocilizumab for his COVID. He improved, discharged, and continued to have dyspnea on exertion, which is not surprising in a COVID patient. However, his X-ray was suggestive of pneumothorax along with ground glass opacities. His LDH was very high, and we considered that he might be having a pneumocystis cerevisiae. However, we could not follow him up further as he was lost to follow-up. And we know that pneumocystis cerevisiae has been reported in other COVID-19 patients, especially in HIV. So we see that we have seen 5 different cases where different organisms which were either present already as colonizers in the body, and they cause significant diseases in these individuals who suffered from COVID. So to summarize, I would like to say that we should have a high index of suspicion for bacterial, mycobacterial, fungal, and viral infections in these patients who are having unexplained worsening or are non-responders. These infections can present simultaneously or may present weeks later. As we know that there are many confounding factors that may make it difficult to diagnose and manage these cases. We do not fully understand the immunopathogenetic factors that favor certain organisms. And before administering immunosuppressive therapy, we should keep in mind that there might be latent infections in these people. To address this, we need to develop new algorithms, and so that more standard care can be provided and a quick decision can be made. Thank you very much for your patient listening. Have a good day.
Dr. Deepak, thank you very much for that very interesting slant on COVID co-infections. I'm now going to pass on to the next speaker, who is also going to take over from me as moderator of the second half of the symposium. And the next speaker is Professor Serhat Unal, who's Professor of Medicine at the Hacettepe School of Medicine in Ankara. And he's going to be giving us his assessment of COVID in Turkey. Thank you.
Thank you very much, dear Matthew. All colleagues from all over the world, good morning, good afternoon, good evening. We, as the ISAC Society, we are very glad to run a meeting like that. And so far, we heard very successful and marvelous presentations. And I would like to go on with the situation in Turkey. Turkey, we are 83 million people, and the median age is about 31.5, a young country. But although we are young, as you see here, the numbers, we have 450,000 confirmed case, and so far more than 12,000 deaths because of this infection. And all the other countries, Turkey is doing his best to fight against that. and we have a decision-making tree as the overseer. We have a case definition. We do the test and evaluation all the patients for risk factors, and according to their clinical situation and risk factors, we take them into quarantine at home or in designated area, or take them to the hospital. And in the hospital, like all the other countries, again, we do our best to treat our patients using the most of favipiravir, heparin, remdesivir, dexamethasone, and the monoclonal antibodies. But here, I'd like to notice two different things. We believe that we do different than the other parts of the country, and we believe that they are successful. As we do the testing over here, a system, what we call contact tracing system, gets into the action. And we have a comprehensive contact tracing strategy. Now we used to have more than 6,000 field teams. It's gone up to 7,500, each consisting of 3 personnel. They are generally the healthcare personnel supported by the teachers in the country. And there's a special software to monitor all the tracking activities. And the 99.5% of all contacts were reached immediately. What I mean over here, once the test is gone into the system as positive, and a team is being assigned to go to the home of that person, they visit him about 5 to 6 hours after the test positivity, and they inform him that he is positive, he or she is positive. And again, being different than the other countries, we start treatment, oral treatment at home for each patient, not only for treating him, but to reduce down the transmission period, if it's working. I'm not very sure of that. And they get the list of the contact people, and that list is given to the center, and the new teams are responsible to follow all those new contact people. And once they reach the contact people, they do the test, and the positive ones are given drugs again, and the system is working like that. And everything, all those tracing activities are being followed by a central computer system, real time, as you see over here. And in each province, they can see how many positive people are available, how many of them has been reached, how many of them given drugs, and how many of them traced for the contact, as you see the numbers over here. And as it was followed as general, and each city, as you see the names of the cities over here, they are followed city by city for the tracing of the positive people. And again, as general, the success of the tracing is depending on how fast we reach them. And once the patient has been reached by the tracing system and giving the treatment, 48 hours after, another doctor, this time his doctor, calls him back and asks his situation, how is it going? And of course, each patient has been warned about the severity of the symptoms. And if they are severe, they have already been informed which hospital are they going to go. They have to call the system and get an ambulance and transfer to the patient to the hospital, a pre-decided hospital, if the symptoms are getting worse. And the other system, we believe that it's different than the other countries, but there are other examples in the other countries as well, not very often. What we call Life Fits Home. We use that acronym because we promote to stay at home for all the people, and it's an application that has been developed by the Ministry of Health with the GSM operators. Once you get in the system, you can see your area. Is it hot zone for the corona, or you can see what other sides of the city is hot zone, which places are dangerous, and it gives if you are travel to those places, it calculates your risk score, and if you give the names of the people, but of course by the approval of those people, generally the family members, they are followed for the risky behavior. and there are a self-check system also whether you may have a coronavirus or not. And there are different methods to go into that system, to register the system. You can do it via SMS, or you can get the program in your telephone or via e-state system. And once you are in there, it checks your test situation and gives you a code. Is it positive or negative? And if you have to travel, you have to go through that HES system and prove that you are negative. For example, if you want to buy a ticket to a train or airplane, you got to prove that you are HES negative. And if you are in a risky situation, you may be positive, or you may have a contact with the risky people, or you may be living in the same house with a positive person, then your situation turns into the risky, and you are not allowed to walk around or to travel. And depending on the severity of the attack, the HES code is required in many different places. Even when you want to go into a shopping mall, or you want to go into an official building, they may ask you your HES code. If it's positive, you are warned and went back to home. And so far, millions of people have been tested, and millions of the people have been recorded to that system, followed for their risk code. And another good thing, I mean, all the countries are doing that, but Turkey has published lots of guidelines in many different situations, and they have been published as publication, as you see over here, or over the internet. And in my last 3 slides, I would like to mention another effort of Turkish country. We are involved in the phase 3 of 2 big international studies for vaccine, and try to help them to develop. And one of them is the CoronaVac. It's Sinovac company, a Chinese company, and it's a whole cell inactivated virus. Phase 1 and phase 2 were quite successful, and we are involved in the phase 3 study. We enrolled the first patients in mid-September, and there are 24 sites are following the patients. So far, we have vaccinated more than 1,000 volunteers for the first dose, and more than 500 volunteers for the second dose. Totally, we came up to 1,600 doses of vaccination as it was yesterday. And we are we'll reach up to 13,000 volunteers, or when we have enough positive people, it is a 1-to-1 placebo control double-blind study. When we reach enough positive patient after vaccination, we will break the code and try to understand the efficacy of the vaccine itself. Here you see the enrollment numbers of the 24 centers, and we evaluate the safety. Actually, independent safety evaluation committee is evaluating real-time, following all the side effects, and they do a general evaluation in each 500 vaccination dose. Total so far 880 volunteers. Side effects, as you see over here, in over 880, there are 108 volunteers has 216 adverse events. 11% of them were local and 30% were systemic. Grade 4 adverse effect, we haven't seen any, thanks to God. And the 8.4% of local side effects, and the 11% of the systemic ones are related with the vaccine. And the most common ones is the pain in the vaccination site, fever, fatigue, headache, and muscle pain. We believe that we will be able to reach the code breaking point in the middle of December. And another phase 3 study is the Pfizer study, cooperation between Pfizer and BioNTech company. It is a mRNA vaccine, as you know, covered by the lipid capsules. And there are 9 centers being involved in the study. And so far we have vaccinated, I mean, total quota was 500, so we completed that. and going on the second vaccination in 3 weeks, we came up to 280 patients. And so far, we did not have any serious side effect. Beyond that, in Turkey, there are 14 vaccine candidates in different technology. Only one of them could reach the phase 1 study, still being running in phase 1, and all the others on the R&D preclinical study. And that phase 1 vaccine, we expect him to get into the phase 3 about April of the next year. And I'll stop here, and thank you very much for your attention. And I'll stop sharing. And without any delay, I would like to go on the next speaker. Next speaker is also from the same part of the world, from Lebanon, Dr. Souha Kanj. My dear friend Souha is a professor of medicine in American University of Beirut Medical Center, Lebanon, and he is also consultant professor at the Duke University Medical Center, USA. And Souha will talk about the PPE and healthcare workers in her country. Yes, please, Souha.
Good evening, good morning, everyone, and it's a pleasure to be participating in this ISAC webinar around the world. I was asked to speak about COVID-19 in Lebanon and the Arab countries briefly, and then speak on the personal protective equipment. So if we look at the beginning of the pandemic in the Arab countries, as we see here, data from the beginning of the pandemic shows that Iran, Saudi Arabia, and Egypt were among the countries that had reported the largest number of infections. This is a more updated slide looking at 3 different things. In yellow, the active cases, in red, the death, and in green, the recovered cases in terms of percentages. And as we see, there's a wide variability among countries in the Arab world. I'd like to point your attention, for example, to Yemen, where the mortality was much higher than the rest of the Arab countries, 29.2%. This is very likely related to the low number of testing in this country for the reasons we all know. Another country that has also reported a high percentage of mortality is Sudan, for example. And if we compare and contrast with data from Lebanon, for example, where we have low mortality here, as well as Jordan and Saudi Arabia. This is the number of the confirmed deaths. This is by November, mid-November of this year. As we see, the largest number of deaths were reported from Iraq, followed by Egypt, Saudi Arabia, Morocco, and Tunisia. But truly, if we look at the number of tests that are being performed per each country, you could see the wide variability. For example, if I take here Saudi Arabia, as of November 20, for each positive test, there are around 100 tests that are being performed. Similarly, for United Arab Emirates, for each positive test, 100 tests are being performed. And if I compare this to, for example, Libya, where for each positive test, there are only 3 tests that are being performed. And therefore, it's really very difficult to compare because strategies for testing are very different from one country to the other. So I come now to Lebanon. As you know, Lebanon has been called for decades the Paris of the Middle East. And for many, many decades, we enjoyed a very good life here. Unfortunately, decades of government corruption led the Lebanese currency to devaluate, and it led to a true economic meltdown that occurred in October. This happened with the background of humanitarian disasters and human and years of environmental degradation. And Lebanon in 1 year went from being listed as a WHO middle income country to ranking only second in terms of inflation rate. As you see here, this is Venezuela, which is ranked as the #1 in terms of world inflation rates, and Zimbabwe was #2, and now Lebanon has moved to occupy the 2nd place. And so Lebanese took to the streets on October 17 in protest against the government, and currently it is believed that millions of Lebanese people, as well as 1.2 million Syrian refugees, are impoverished. It's around a quarter of the Lebanese living below the World Bank poverty line, and a third of the nation have no jobs, 50% with no health insurance. So this was really a transformative year, and so COVID-19 came to hit us in the worst year ever. If we look at data from Lebanon on April 2020, we were still doing quite well. The overall testing rate was 17 per 1,000, which was very comparable to the global average of 15 per 1,000. The positivity test rate was 1.5%. And at 251 cases per million persons, Lebanon compared very favorably with New Zealand, South Korea, and Australia. And there were many laboratories that were doing COVID-19 testing, and around 10% of the country's hospital beds were dedicated to COVID-19. The number of ventilators was, though, on the low side, and this was a major concern. And actually, there was a report in the Washington Post in April saying Lebanon is in a big mess, but on coronavirus, it's doing something right. And in that interview, I had to say that in a way, it's good that the Lebanese people were so scared and panicked about COVID-19 because it forced them to be very vigilant. And that led to really having low numbers initially. However, what we encountered in Beirut in August 4 was catastrophic. You've all heard about the blast that hit the port. 2,750 tons of ammonium nitrate exploded. It led 300,000 people homeless, 6,000 injured, over 200 deaths. And many hospitals were significantly damaged by the blast. It was estimated that 55 healthcare facilities were rendered non-functional following the blast. And also what was very sad, that 17 containers that had essential medical supplies, including personal protective equipment, as donations to Lebanon in view of the economic crisis, were totally destroyed by the blast. And these are images of the Beirut port before the blast and after the blast. And so basically what happened, you can imagine that as a result of the blast, all infection control practices were breached at many levels. This is from the emergency room, and as you see, people are not wearing masks, very close to each other. And not only that, you know, my own hospital received around 500 casualties. 20 passed away on arrival, and in a testimony by one of the ER residents, she said not only people were not masked, but they ran out of medical supply. They used the same blades, gloves were not changed, staples were reused on the same patient. And this is in a hospital that really operated by the highest standard of infection control, and you can imagine the chaos that this created. And so following that, as I mentioned earlier, we had quite a low number of COVID cases, but following the port blast, we started to see a marked increase in the number of cases, as you can see here. And as of November 21, we had 118,000 cases. And if we look at the testing rate, it's 3,000 per 100,000 population currently, and the positivity rate is around 15%. Now, if we look at the mortality per age group, the overall mortality is 0.79. So it's really low compared to some of the other Arab countries. But as we've seen in many other reports from the globe, the mortality is much higher in the older age group, where it reached a peak in people who are above the age of 70. What about healthcare workers? As we know, this is a significant concern. In Lebanon, we had around 1,600 healthcare workers that were affected. As of November 24, we had 1.41% of the cases in Lebanon were in healthcare workers. And so if we look at various studies that have looked at the rates of infections among healthcare workers compared to the general community, the frontline healthcare workers had an adjusted hazard ratio of 3.40 for reporting a positivity test. And the rates were the highest among healthcare workers who reused PPE or those who had inadequate access to PPE. And in a recent survey done by Hagan Erdem from Turkey, where they looked at infections among healthcare workers in 37 countries, the median of healthcare workers death per 100,000 population was 0.05, but as you see, it ranged from 0.01 to 0.9. And these are images from the Faroes, the Alpha Omega Alpha journal, showing images of the damage that the PPE can create to healthcare workers. Now, I will not speak in details about the transmission routes of COVID-19. I believe Professor Bell will talk about this in his presentation. But as we know, the majority are mostly concerned about droplet versus aerosol transmission when there is an aerosol producing procedure. The types of PPEs that are used in healthcare setting, the gloves, the gowns, apron, the overall suits are used particularly in the intensive care units. The masks and respirators, either N95 mask or the filtering face piece or FFPs are also used particularly in intensive care units, goggles to protect the eyes and face shields on top of the masks in some scenarios. And here on the right side is just the estimate by WHO of the monthly need of the personal protective equipment. And as you see, this is a humongous number for masks, gowns, goggles, and other PPEs. Now, ideally, obviously, if we have enough N95 masks or FFPs, this is what's recommended, as I said, particularly in patients in the ICU, who, you never know when you need to intubate or you need to give them inhaler treatment or BiPAP or CPAP. An alternative that is recommended is to use a face mask when the N95 or FPPs are not available. But it's also very important to use the language that the employees can understand. All employees, for example, in my center, we made up brochures for how to use the PPE with the translation in the Arabic language, because there are some of the employees, such as the housekeepers and others, who do not read English. So we really need to make it accessible and understandable by all hospital employees. Now, as we know, there has been a lot of debate whether we can use surgical masks versus the respirators N95 or FFPs. This is a study looking at high quality surgical masks, which appear to be as effective as FFP2 mask in preventing droplet-associated viral infections in healthcare workers in the days of influenza and in the SARS-CoV-1. So far, we don't have a head-to-head trials comparing the face mask to the N95 or FFP in COVID-19. Obviously, we need to always ensure that they're well placed and well used because if there are breaches, none of the masks can be 100% protective. This is a meta-analysis looking at 4 randomized controlled trials, basically showing that medical masks are not inferior to N95 respirators for protecting healthcare workers against the viral infections, and the numbers are mentioned here with the confidence intervals. I found this nice review published by Sommerstein et al. And our friends Andreas in the Antimicrobial Resistance and Infection Control Journal a couple of weeks ago, very easy to read. And it really talks about how we need to really individualize sometimes the decision depending on the scenario. So for example, if the patient is just regularly speaking, you can imagine that the droplets will be released only for 2 meters, whereas if you have a patient who has a hacking cough and having a severe cough, the droplets might be propelled for up to 8 meters. And obviously those who have aerosol generating procedure, this is definitely an indication where we need to be using the FFP2 or N95 masks. This is an old study from 2012, and basically it looks at SARS-CoV-1 and looking at the procedures that significantly increase the risk for aerosol transmission of SARS-CoV-1. And as you see, tracheal intubation had an odds ratio of 6.6, non-invasive ventilation 3.1, tracheostomy 4.2, and manual ventilation before intubation 2.8. And so therefore, if we look at the CDC listed procedures that are now considered aerosol generating procedures, some of the ones that I've already mentioned, but including others such as induction of sputum, some dental procedures where we have high-speed drilling, and upper gastrointestinal endoscopy where there's going to be suctioning. So it's important whenever we're doing any of these procedures to use an N95 or FFP2 masks. What about other pieces of PPE? And in this systematic review and meta-analysis, they assessed various PPEs, but if we concentrate here on eye protection, face shield, goggle versus no eye protection, and as you see, there were 13 studies looking at this particular question, and the conclusion was that eye protection might result in a large reduction in virus infection. And so basically, this is what we're doing now in my hospital. Whenever we round on the patients who are coughing, we are using goggles in addition to the masks to decrease the risk of infection. As we've heard from Benedetta at the beginning, there's a worldwide shortage of personal protective equipment. And you can imagine that in some countries, this is being felt much more because of the economic crisis, and Lebanon is just one example. What we have seen since the beginning of the pandemic, that locally made protection gowns and cloth masks started to be made. We also, in our facility, we looked at ways to sterilize the goggles and the N95 mask, and we found that by doing so, there was a tremendous cost saving. For example, for the N95 respirators, there was a $60,000 cost saving by doing the re-sterilization. In addition, engineers from the university looked at developing a reusable respiratory mask as seen in this slide. Also, there was an innovation triggered by the COVID-19 crisis site where people put on the site what they worked on to help managing the pandemic. So some engineers came up with the ventilator that was locally made. These boxes that protect the healthcare workers during intubation, and as well as I mentioned the overall suits and the locally made face masks. This is the end, and these are some pictures from Lebanon. For those of you who have not had the chance to visit, I wish you had the chance to visit before the crisis, but hopefully Lebanon will rise again one more time and you'll be able to visit. Thank you for your attention.
Thank you, Souha, for this excellent review. And Dr. Kanj was a member of ISAC Executive Committee, I forgot to say, and our next speaker is another member of ISAC's Executive Committee, Dr. Sade Ogunsola. Dr. Ogunsola is Professor of Medical Microbiology at College of Medicine, University of Lagos, Nigeria. Also the member of the African Citizen Testing Steering Committee for COVID-19. And he will talk about the universal masking, please.
Good morning, good afternoon, good evening. I thank the International Society for Antimicrobial Chemotherapy for inviting me to speak and to give this overview of COVID-19 in Africa with a short rationale for why Africa went for universal masking. I'm Sade Ogunsola. I'm a professor of clinical microbiology at the University of Lagos in Nigeria and the present chair of the Infection Control Africa Network. I'll be giving a lecture with the outline COVID-19 in Africa, the Africa Strategic Response, a universal masking, and some thoughts on the challenges to our sustained response, and then a small summary. Africa's population is about 1.347 billion, and it forms 16.7% of the world's population. 60% of Africa is under the age of 25 years and 75% under the age of 35 years. The initial infections were all imported and they tend to affect urban areas first. All 55 countries are presently reporting cases, and the efficacy of the control varies per country. As of 15th of November, about 1.89 million Africans were infected, and this formed 4% of the global total. The southern region is the most affected, and this is mostly driven by South Africa. To date, only 45,609 deaths have been recorded from COVID-19, and gives us a case fatality rate of 2.4%, which is not too different from the global average. Globally, deaths from COVID-19 peaked in April, and presently many countries are undergoing a second wave. New cases in Africa and deaths appear to have peaked in July. And despite this, it's been a very low, the graph has been very low, what we call a sort of slow burn. And if you look at this comparative graph, this is Africa just right down there. So the impact of COVID-19 has been relatively low. Well, this was despite or against the predictions. In May 2020, WHO estimated that up to 190,000 persons could die from COVID-19 in Africa. And they had good reasons to worry. Though sub-Saharan Africa accounts for 1% of the world's population, it accounts for 24% of the total global disease burden and less than 1% of the global health expenditure. There are issues of inadequate supplies and equipment for health. There are major human resource gaps for health. Only 30% of the population have access to primary health care. There's a high rate of out-of-pocket expenditure for health. And there's very poor health-seeking habits. Part of this are trust issues with healthcare. There is also a low critical care capacity for COVID-19. Analysis of the number of hospital beds, physicians, ICU beds, ventilators, and physicians, anesthesia providers, and non-physician anesthesia providers show that in all cases, the region is not doing too well. There are less than 300 beds per 100,000 population, with the best cases coming from Southern and Northern Africa. But this is probably the best scenario. When you get to ICU beds, it becomes really dire. Nowhere in Africa is it up to 10 per 100,000 population. Ventilators, even much worse. Physician anesthesia providers are available in Southern and Northern Africa, but very little or even negative in West Africa. But Africa somehow defied the gloomy predictions. If you look at the deaths per 100,000 population, I looked at the top 10, the rest of the world, and you look, so the top 9 in the rest of the world, and then the top 9 in Africa. The difference is stark. Belgium with 125 per 100,000 population. And in South Africa, which has the highest rate, is only 34.97 per 100,000 population. And it goes down like that. By the time you're getting the 6, it's about 7 or 8 per 100,000 population. So the difference is really stark. But why did this happen? One of the things we do know, well, it's probably a lot of things, but one thing is that Africa responded very early and leveraged its experience with previous epidemics. The African Union decided to coordinate the response amongst all the countries and had started monitoring the disease from early January. By the 27th of January, almost a month before COVID landed in Africa, it had activated its Emergency Operations Center. And by the 22nd of February, which was a week after COVID came into Africa, the ministers of health adopted the Africa Joint Continental Strategy for COVID-19. And the African Union set up, the African CDC set up the Africa Task Force for Coronavirus to implement that strategy. And that strategy was around had 6 technical working groups that looked at training, infection prevention and control, research, logistics, case management, and guidelines that were contextualized to the African continent. It also activated its Africa Health Volunteer Corps, a network of African medical and public health professionals established by the African Union after the Ebola epidemic to support the response to public health emergencies. Just to also say that at the present time, Africa is undergoing a lot of events. Right now, there are 106 outbreaks in Africa, in many countries. So many countries are handling multiple outbreaks. What the African Union through the CDC did was then to build continental capacity at a very rapid stage. So they looked at case detection and containment was addressed. They worked on testing. There was collaboration between the African CDC, the WHO, the West Africa Health Organization, which led to an increase in COVID-19 labs from 2 to 43 between February and mid-March 2020. Training was also going on at a breakneck speed. There was surveillance at points of entry, training on surveillance at points of entry, infection prevention and control, risk communication, and clinical case management. Initially, these trainings were face-to-face workshops. Later, they became online webinars. in early March because of border restrictions and close downs. Over 6,000 healthcare workers, epidemiologists, contact tracers were trained centrally across Africa, and many of these went to their countries to do step-down trainings to others. The continent decided to have a pooled procurement strategy of diagnostics and other medical commodities to strengthen our bargaining power and stabilize costs, which initially went sky high. This was launched through the Partnership to Accelerate COVID-19 Testing, PACT initiative by the Africa CDC. The response in Africa was related to the stage of the pandemic. So you had at the initial stages screening at ports of entry, which occurred even before COVID-19 was at any port of entry in many countries. And they went on to isolate all positives in health facilities. There was quarantine, intense contact tracing, often aided by technology. There was testing, social distancing, cough etiquette, hand hygiene. There was isolation of positives, later on isolation of positives in the community and homes. There was isolation of moderately to severe patients in healthcare facilities, and quarantines continued, intense contact tracing continued as the epidemic intensified and we started having community outbreaks. And at this stage, universal masking was introduced. As transmission continued, and in some places appeared to reduce, self-isolation at home continued, and universal masking had become very broad-based in Africa. This was in addition to hand hygiene, cough etiquette, social distancing, and limitations in traveling, which have not totally been. There has now started reopening of schools, and so the issues of universal masking and all the other messaging has been intensified. The response to COVID-19 was swift. If you look at it in January, screening at ports of entry, Ethiopia began this intensive screening at Addis Ababa airport. This was even before COVID-19 came in. In February, the Africa Task Force for Novel Coronavirus was created. Screening and training was ongoing. In March, countries like Rwanda, South Africa, Nigeria had travel restrictions and lockdowns. And these occurred even when they are, for Rwanda, it was even before they had cases, but in Nigeria and South Africa, a few cases and they locked down. And by April, many African countries had adopted masking. The good thing though was across Africa, there was generally cooperation by the people. Morocco was the first country to make masking mandatory, and this was in April, and they actually also had consequences. So if you did not mask in public, people were fined or jailed for 3 months. It was followed soon by Tunisia, South Africa in April 10, Lagos State in Nigeria, April 25th. Kenya, after these first 80 cases, started masking. By now, and all this was before the WHO advised universal masking, June 5th, 2020. The reason for this was not far-fetched. Africa recognized its many problems in terms of managing COVID and decided that prevention was best, and that any additional, even partial reduction of transmission would be useful in slowing the epidemic. And face masks, though not perfect, would provide some of this protection, because we do have a lot of challenges with social distancing. There are over 200 million people living in slums in Africa, and many Africans are daily paid, so lockdowns were difficult to maintain. We also have the highest rate of people who go to church and take it extremely seriously. For example, in Nigeria, 89% of people would go to church. We also recognize that universal masking will reduce the concentration of droplets that fall on surfaces, and would also, because of asymptomatic or pre-symptomatic transmission, help to reduce this kind of transmission. It was also pushed that face masks would act as a symbol of shared responsibility and collective action, which resonates with Africans who are very community oriented. So why was there less severe impact of COVID-19 in Africa? Probably multifactorial. The early response is probably a factor. The youthful population, very possibly, because we do know that COVID-19 is more severe in the elderly. Low testing rates might account for the low numbers, but do not account for the fact that we don't have an excess of mortality on the campus, on the continent. Previous exposure to a similar virus, this is very feasible, and some cross reactions have been found. Climate, we're not sure about that because many other continents have similar climates in places. Lifestyle, it's possible. A lot of Africans live outside and do not have air conditioners, so windows are thrown open. This might account for dilution, but still needs to be proven. Vitamin D, well, it is feasible. One of the things we found in Africa, or at least in some countries, is that it does seem to be affecting those in the higher income rates who appear to live indoors more than those who appear to live outdoors. But that again is a conjecture and needs to be proven. Genetics, probably not, because in places where Africans have migrated to, like North America, South, and to the UK, the colored people seem to be impacted more negatively. So it can't be totally a genetic thing. We also want to note that Africa was not significantly impacted by SARS-CoV-1 or the MERS-CoV virus. And a recent report by Lancet speaks to this. And it's important that a lot of Africans go to Saudi Arabia and to the Middle East for trade and for religious purposes. So presently, we do have challenges to this response. We have a challenge to continued adherence to messages. Many Africans do not believe there's COVID-19 or believe it has gone because of this low impact. Somehow the hand hygiene message resonates a lot more than mask wearing. And there has been, in recent times, a reduction in mask wearing, or even when there is no reduction, there's an ineffective mask wearing where people are wearing it at their chins. The adherence to physical and social distancing is waning. We're beginning to see weddings and funerals in some places. And we're also beginning to see more cases, though these are still relatively low. So in summary, the response of Africa to COVID-19 was swift and coordinated. The response was contextualized to a situation. The slow burn is probably due to a combination of youthful population and swift response to and perhaps other factors. And the low impact of COVID-19 is challenging, as there is now a growing belief on the continent that COVID-19 is gone. And this is affecting adherence. So I want to thank you for listening. And just to say that recently, CDC modified its recommendation to say that facial coverings are not only useful as source control and may provide protection for the wearer. I would also invite you to join us for the Africa Mask Week from the 23rd to 30th November. Thank you very much.
Thank you. Thank you, Dr. Ogunsola. Looks like Africa is less affected by SARS-CoV, and I hope it will go on like that and will not be more severe effects. Now we are coming back to Europe now. My dear colleague, Dr. Matthew Dryden. Dr. Dryden is a member of the ISAC Executive Committee, and he's the Professor of Medicine, St. George University, Grenada, and he's consultant microbiology and infectious in Department of Infectious Diseases. And he will talk about the uncertainties in COVID-19. Please, Matthew.
Thank you very much, Serhat. I'm just going to share my screen. There we go. So I've been asked to cover COVID uncertainties with reference to the UK. So thank you very much for that introduction, and it's a great pleasure to be speaking on this symposium. Many of us are now experts in COVID, and it's often very hard to establish well-documented evidence from uncertainties. And I'm going to touch on a number of these topics: epidemiology, diagnosis, immunity, treatment and vaccination, control of the pandemic, as well as infection control, and some of its uncertainties. And I guess the first uncertainty is where the virus has come from. It's a zoonosis. It's almost certainly come from bats, but it may well have gone through another animal vector. And at the moment, that's uncertain how it transmitted from bats to the human population. When the epidemic kicked off, the first evidence that there was a problem with a new virus for mankind was in January, when there were a number of cases of pneumonia of unknown etiology in Wuhan in China. That rapidly spread so that the first case outside China was in January. And there's been some debate over whether the virus existed for some time before that, and indeed whether it was prevalent in other countries before it emerged in Wuhan. Perhaps some of the genomics we've heard about today will explain some of that. But the virus rapidly spread across the world, with the first cases in Europe towards the end of January and clusters in many European countries subsequently. So that from there it spread really globally, and the whole world has now been affected. And you can see from this chart the international epidemiology showing the number of cases in each different region. And there are some gaps. We've heard some fascinating data from Africa from the previous speaker, but the relatively low incidence there may relate to inaccessibility to regular testing. And down in Australia and New Zealand, they've been very effective at controlling COVID and keeping COVID from entering their borders. And so again, the rates are very low there. What the UK tried to do when the outbreak kicked off was have a phased response to the virus. And initially, that involved a containment phase to try and stop it spreading any further. That was relatively unsuccessful, probably because the virus had already spread beyond the bounds of the initial clusters when they first occurred. The next phase was a kind of delay phase, and the rationale behind that was to try and delay the spread of the virus so that the healthcare services would cope with the number of patients being admitted to hospital, and it was reasonably successful in that in that area. And by and large, the health services managed to deal in the first wave with the large number of cases being admitted to hospital. And I guess we're now in a sort of mitigation phase where we aim to treat all cases and minimize the spread beyond that. And because we've now in the second wave, we've initiated a second lockdown, which aims to reduce further transmission. While all this is going on, there's national and indeed global research looking at all aspects of the management of COVID virus, from treatment to diagnosis and so on. After our first wave, which finished in the middle of May, people got out and about. And because people in the UK were unable to travel, a lot of people flocked to beaches. There were various street parties and marches and so on. And yet there seemed to be very little COVID transmission. Now, whether that was due to some of the preventative factors that we've already heard about in previous speakers, for example, high UV levels, vitamin D, again, is another uncertainty that needs to be established. But we're now in the middle of a quite extensive second wave in the UK. It would appear from this graph that the first wave was much smaller, which of course was not the case, because early on in the UK COVID outbreak, there was only targeted testing. Widespread testing was not available. So there were probably many thousands of cases, asymptomatic cases, which were never recognized during the first wave. The number of cases fell off dramatically over the summer months, as I've mentioned, and from about the middle of September, we've seen a rise and there may be a bit of a downturn this week, but we've been seeing cases in the region of about 20,000 a day for the last week or so, which has precipitated our government to initiate a second national lockdown. We have the unenviable position of having one of the highest death rates in the COVID-19 outbreak across the globe. That again peaked in the first wave in April, fell off dramatically. So there were very, very few deaths over the summer months, along with very low transmission. And we're currently seeing a bit of a lag behind the increased number of cases in the UK, with, again, around 400 average day deaths due to COVID. And these are deaths recorded up to 21 days after a positive COVID diagnosis. So where have we gone wrong, or where have the uncertainties been in trying to control COVID in the UK? I think one of our issues in the United Kingdom was that there was inaccessibility to widespread testing early on in the outbreak. There were some centralized testing facilities, but it was slow to decentralize and have testing available in a more widespread way for the whole population. We had a test and trace system, which was is now established, but has received criticism, but seems to be reasonably effective in picking up cases and in informing contacts. One of our concerns early on in the outbreak was that in an aim to free up spaces in hospitals and in healthcare facilities to manage acute COVID cases, many patients were discharged from hospital early, particularly elderly patients, back to care homes, and unfortunately that resulted in transmission amongst residents of care homes and indeed amongst staff in care homes, with a high attrition rate, a high death rate associated with care homes. And at the time, there was a relative lack of testing available in care homes to establish the diagnosis and control these local outbreaks. Some of the unsung heroes of the COVID outbreak, I think, have been the health scientists, not only professionally trained healthcare scientists, but also scientists from many other walks of life who have come into the system to help set up very rapidly widespread COVID testing in hospitals and other healthcare facilities. So they've done a fantastic job. And some of the centralized facilities, like one of my departments, the Rare and Imported Pathogens Department in Porton Down, has been involved in validating and assessing all the new technology that's emerged through COVID. So a lot of the diagnostic testing, both antibody, antigen, and PCR testing. And we've been able to rack up the facilities for national testing in a very quick way through these facilities. On the clinical side, most hospitals have been very busy with COVID admissions, and the spectrum of clinical presentation of COVID, again, there's a certain amount of uncertainty. It's thought that most cases are asymptomatic, and it may be up to 80–85% of cases are in that category, having been asymptomatic. Some develop minor illness. More severe illness starts with pneumonitis and reduced oxygenation, and those patients get admitted and are managed in hospital. And then once they often start to recover from this, an immunological mechanism kicks in, which may cause further damage, a cytokine storm with multi-organ failure. And many of our management strategies have been developed around trying to prevent some of these issues. The teams working on these patients have been multidisciplinary, and this is outside our intensive care, showing intensivists, respiratory physicians, general physicians, junior doctors, research nurses, and even an orthopedic surgeon propped up in the corner there. And the sorts of patients that become increasingly unwell are those who develop worsening respiratory functions. So a normal CT scan on the left with a COVID pneumonitis, and we've heard about some of the secondary infections from India that are associated with these, making the illness worse on the right. Research is absolutely crucial in reducing uncertainty in treatment, and I think one of the great successes in the UK has been national randomized controlled trials looking at various treatment arms in patients admitted to hospital with COVID. And these have looked at a number of potential treatments which have subsequently found to have been ineffective. For example, hydroxychloroquine and the antibiotic azithromycin. There's even emerging evidence that the antiviral remdesivir does not improve outcome, but I think the data needs to be looked at a little bit more closely. What it has done is showed those areas where treatment regimens appear to be very helpful. So dexamethasone, where there's a reduction in oxygen saturation, anticoagulation, prone ventilation, and immune modulators at the bottom. The national trial that we have looking at these different arms of therapy is called the recovery trial, and the arms may be added or removed depending on what the national data shows. So that the first evidence that dexamethasone was very, very helpful in improving outcome in COVID patients was as a result of this recovery trial some months ago. I guess the next uncertainty too is immunity. We've heard a little bit about immunity already, but what we found, most patients you would expect to develop, to seroconvert and develop IgM and then IgG following an infection. But we've shown that a number of asymptomatic patients may never develop antibodies. There are indeed some asymptomatic patients who do develop the normal antibody response as you would expect. We've had other patients who are PCR positive, but never develop an antibody response. So there's a certain amount of uncertainty about the immune response to the virus itself, and indeed how long the duration of immunity will last after an infection, and will secondary infection result as a result of fall off in immunity. It was interesting hearing the Australian talk about genomics, because that would seem to imply that second infections are not occurring, but it's prolonged secretion of the virus. We don't know whether other immune mechanisms are important. Is mucosal IgA important, or T-cell immunity crucial in the control of infection with COVID? Is there any cross immunity with other coronaviruses? All of these are uncertainties. We also in the UK have multiple vaccine candidates, and these are the trials, as in Turkey and in many other countries, are starting now. Infection prevention, we've heard a lot about masks already, but I think ventilation is probably very important. In the second wave, in a number of hospitals, we've had nosocomial transmission of COVID from staff and from patients to patients. And that seems to be as a result of poor ventilation in many of the older hospital structures and hospital bays. If you can improve ventilation and probably wear masks as well, may well reduce that, there's a reduction in COVID transmission. Research is looking at many of the control methods for COVID, both within hospitals and within the community. And I think this is quite an interesting chart showing that you need 1,000 quarantine days to prevent one transmission by just locking down regions. So locking down regions does not necessarily reduce transmission very quickly. But if you quarantine contacts of known positives in a test and trace system, then you only need 70 quarantine days to reduce a case of transmission. Similarly, a lot of individual assessments are important, and I won't go into all of these, but you only need 5 quarantine days to reduce one case of transmission if you quarantine a PCR positive person at the time of onset of COVID symptoms. So that's pointing towards a requirement for widespread testing and quarantine of positive cases to reduce transmission to local contacts. And that has been distilled in the UK into our slogan of hands, face and space. So hand washing, face covering and keeping your distance, as we've heard from so many other talks today. This is almost my last slide, but I think it's also an uncertainty whether media helps control COVID. There's a view that media sensationalism can push politicians and indeed public health physicians into acting in a way they wouldn't have done otherwise. So obviously it's very important to have public information, it's very important for communication, but I think we have to question too whether media sensationalism may also be dangerous at times in controlling a pandemic. So what's the future? Well, I think the virus is always going to be with us. It's a global virus, it's new to mankind, and it's not going to go away. I think we have to improve universal testing. We need to maintain, as individuals, the slogan of hands, face and space to reduce transmission and quarantine people who test positive. So on that note, I will stop and thank you very much for your attention.
Thank you very much, dear Matthew. And now we change the continent and go to Americas. We will go on with Dr. Mike Bell. Dr. Bell is the Deputy Director of the Division of Healthcare Quality Promotion, Centers for Disease Control and Prevention. He also serves as the Executive Secretary to the U.S. Federal Advisory Committee, Healthcare Infection Control Practice Advisory Committee. And he's going to talk about the PPE from the perspective of the transmission dynamics. Please, Dr. Bell.
Thank you, Professor Unal. And thank you to ISAC for this very timely symposium. It's been wonderful to hear everyone's thoughts. I hope you're all staying safe and doing well during this terrible time. I'd like to share a few thoughts on PPE and broadly infection control related to what we've seen to date. In the United States right now, as with many other locations, we're seeing a second wave that continues to increase at an alarming rate. Most of what we're seeing seems to be driven by community transmission. And as you just heard from Professor Dryden, long-term care facilities and other congregate settings are particularly vulnerable. I can say that overall, this pandemic has been notable in that it is unmasked many weak spots in our healthcare system nationally. In the United States, a great deal of medical care has gradually shifted to places like nursing homes and long-term care facilities. And unfortunately, in many situations, those facilities did not build what we would consider the usual infrastructure for infection control to go with that care. That is something that I think we're seeing in many situations, as well as places where we don't provide care, whether it's summer camps or other settings of that sort. We are seeing some weak spots in our fabric of society, if you will. The hospitalizations we've seen, as others have mentioned, have largely focused on the elderly. The severe outcomes have also been linked to obesity. We are seeing that healthcare systems and resources, especially intensive care units, are very stressed in many regions of the country. Our staff are very fatigued and largely overextended, and we are very concerned as we plan for how to manage this ongoing second surge. We have some hope with vaccines, but the impact and timing of availability, and frankly, in this country, uptake remains to be seen. And so, it's a light at the end of the tunnel, but it's not quite clear how near that light is. When we think about transmission, however, I think it's good to remember that it's not just one thing. You heard a few thoughts just now from Professor Dreyer, and others have commented as well, that there are many things that go into thinking about transmission. And I think that's an important part about considering PPE. The infectiousness of the source is primary. I'll say a little more about that in a moment, but also the proximity to the source, the type of interaction, the duration of the exposure. We're seeing that there's clearly a strong correlation between protracted exposure versus brief exposure. Some of that is just the likelihood, I think, of encountering somebody infectious, but also in a shared airspace, the cumulative exposure to poorly ventilated air is something that we're seeing as a risk factor as well. I'm sure many of you have read of the examples in this country of choir practices that led to very impressive transmission rates in a closed space. This is with everyone being asymptomatic. Similarly, we've seen exercise facilities in closed spaces where people exerting themselves have done a very efficient job of spreading infection, again, without being actively symptomatic. And lastly, I think there are some tour bus examples that we've seen where poor ventilation was very much associated with efficient transmission. And this gets to the next point, which is the pre-symptomatic or asymptomatic infectivity. This is probably the most challenging feature of this disease, the fact that people can be spreading infection without knowing that they're ill. All of this taken together, I think, has gradually in the United States shifted our focus much more towards respiratory aerosols, as opposed to our initial attention to the environment and fomites. We still take precautions to ensure that the environment is clean. We still emphasize the importance of hand hygiene, but not just for COVID-19, for all pathogens that we don't want to spread around. Those things remain fundamental. But in terms of special attention for COVID-19, we're focusing a great deal more on respiratory aerosols. Here I'd like to share a study that demonstrates dramatically the efficiency with which people are able to generate respirable aerosols, very small particles. You can see at the bottom, I'll point at it here, the range of particle sizes. And here we are all very much in the respirable range. And the amount generated per second increases with both the vigor and nature of breathing or communication. Singing is at the top, but loud talking is also prominent here. I share this because there are additional data showing similar patterns of routine generation of aerosols in a way that I think as a field, infection control has been reluctant to talk about. I think it creates a prominent challenge when we start to grapple with the fact that everyone is creating small aerosols pretty much all the time. The fact that we haven't looked before doesn't mean it hasn't been happening. And I share these for those of you who might want to take a look at them. Here in particular, I found a very nice synthesis of what amounts to a gray zone. None of this is particularly black and white. And this paper includes the phrase here that suggests that COVID-2 is possible to be transmitted through aerosols, but not very efficiently. And I think that kind of tempered statement is where we're at when it comes to the aerosol transmission of COVID-19. It goes against the common conversation that we hear of is it droplet or is it airborne? I'm afraid that's an antiquated dichotomy. This is based on transmission patterns of near range transmission versus long range. That's valid. And I think the airborne transmission of diseases like measles, tuberculosis, chickenpox, those things reflect the ability of the pathogen to spread long distances through the air. And everything we do to prevent that still makes perfect sense. But at close range, attributing all of that transmission simply to splashes of ballistic droplets, big droplets, to the eyes, nose, and mouth, I think is an oversimplification. And it's increasingly clear that as we generate these respirable aerosols, we're probably inhaling some material when we're close to an infectious individual. Does that completely obviate the dichotomy? Probably not, but I do think we do need to begin thinking about it as a gradient as opposed to a binary. The long distance airborne infectivity piece is something that I think we have a challenge with when we work with our particle scientists who tend to think of particles as static. And I think there, the infection control perspective of understanding the decay of infectivity over time is also very important because that too is part of the near range inhalational transmission picture. We're not seeing efficient long distance transmission. The special cases like the tour bus or the exercise facility or an enclosed singing space, those are examples of where longer distance transmission has been documented, but it seems to be a special case related to poor air handling. I think that when we think about implementation of practices related to this kind of thought, it's nothing new. In the United States, we have fairly consistently, certainly since SARS-1, but also with MERS, pandemic influenza, and now COVID-19, leaned towards using respiratory protection, an FFP2 or an N95, when we're dealing with one of these pathogens. The rationale is that with a new pathogen, we are concerned that a large proportion of the population is likely to be susceptible. That can certainly inundate and overwhelm our healthcare system. And then lastly, with a severe illness and potential for bad outcomes, if we don't have specific treatment or an effective vaccine, as we do for seasonal influenza, we lean towards taking a little bit more of a precautionary approach. The current recommendations for COVID-19 patients in the United States include taking care of patients in a single room, if at all possible. Cohorting is also permissible, but we don't recommend a negative pressure room or an airborne infection isolation room. We do recommend the use of an N95 respirator, but we also provide, as you can see here, contingency plans for supply limitations. Just as every part of the world, supplies in the United States are currently sporadic and sometimes limited, and making the best use of what we have available is what we recommend on the CDC website at the present. We recommend eye protection. We heard a little bit about this earlier, and I will just hasten to remind everyone that anatomically we have a very direct path from our eyes to our respiratory tract. I think it's easy to forget about tear ducts, but when I see people pointing out that there isn't a virus receptor in the eye, in this case there may be, it's important to remember that for any respiratory pathogen, eye exposure is a bad idea. Do we take it seriously all the time for common pathogens? No, we don't. But maybe we should, maybe we will. I think that one good thing about situations like this pandemic is that the equipment we use starts to get a little bit more useful. I'm certainly seeing a proliferation, of more usable face shields, and I think people are getting better at using them. Gowns and gloves are recommended as a basic hygiene augmentation to make it easier to remove soil, whether it's on your garments or your hands. There's not a direct risk of transmission through the skin, obviously, but we do want to be able to take soiled material off of our hands very quickly and very effectively. We still recommend hand hygiene before and after glove use. Before, because we don't want to soil the box of gloves, and after, because people are pretty good at contaminating themselves as they remove their gloves. This is all in combination, however, with routine cleaning and disinfection. We're clear that the routine practices that we use in healthcare are still fine with COVID-19. There's nothing that indicates a need for different chemicals or different practices, but we do want to make sure that we're doing a good job maintaining a clean environment at all times. As you heard moments ago, assessing and optimizing facility air handling is crucial. We want to make sure that all of the standards that we normally recommend are met at a minimum. Augmenting that with additional filtration is fine, but anytime you do that, making sure that the air handling system is still functioning correctly is crucial. I've seen many examples where people thought they were improving things by adding a new filter, but actually changed the air direction flow through their facility and created problems. Bottom line is, make sure that your airflow and air handling in your facility is assessed actively. Don't assume it's okay, even if things look okay, because you really can't tell unless you check. And then the bottom thing is source control. We've heard a little bit about masking for source control, and I think that we're learning a great deal more about it. I'll share a little bit more in just a moment. But before I wrap up with personal protective equipment, I just want to underscore the fact that it's one component of really a package of activities. The effectiveness of PPE is very much limited by the attention to care processes and locations. It is much better to find an optimal location, for example, out of doors with great ventilation, than to do things in a risky space and hope that your protective equipment does its job. Correct use and adherence is, of course, key. We've all seen pictures of people using PPE incorrectly, and that actually is not only unlikely to be successful, it also undermines our ability to ensure that we understand that it's working, right? If we're seeing people become infected despite using PPE incorrectly, that can create an uncomfortable sense of uncertainty. I think we're all very much committed to making sure nobody gets sick in healthcare facilities. And that means we need to keep an eye on each other and make sure that everyone's doing the right thing all the time. I mentioned cleaning and disinfection already, as well as indoor air quality. Those things are part of the package. And finally, source control. Here, I'm just sharing a few resources reflecting the effectiveness and efficacy of source control options. The literature is growing fairly rapidly I think that's very helpful. Here I'm sharing some work from colleagues at CDC who did some very straightforward assessments of various products. In the blue bars here, you can see N95 respirators, and this is for source control, for blocking release of respiratory secretions. And N95 respirators do a very good job, as you might expect. But more interesting, if you look at both the gray bar and the orange bar, so the orange and gray bars here, they actually do a remarkably good job of blocking the release of secretions. Depending on the particle size, we're talking anywhere from 60 to 80%, if not more, blockage of release of secretions. We've also done a bit of modeling to show that even with a 50% successful blocking rate, if half of the people in a population adhere to using a source control mask when they're in public, the impact is actually fairly dramatic. The bending of the pandemic curve is very notable. And so certainly for an intervention with very few side effects, if any, it's well worth considering. There are also observational data to share that look at implementing universal masking policies. And in several states in the United States, there have been notable declines in incidence. Is it purely attributable to the policy? Obviously not, but there does seem to be an association. And so it's probably good not to discount it. Here again, some more evidence that you might be interested in looking at. This is some of the stuff that we've been using to make our interim guidance. At the very bottom is a link to our website that has a summary of our mask guidance evidence package. And you're more than welcome to take a look at that if you would like. So as I think about where we are, I think we are continuing to evolve. There is probably ample indication for thinking again about how we do things. Some of that is in terms of devices. I think that we are looking at a variety of products. The chart that I showed you with relative effectiveness of different products for source control actually has a parallel chart that I don't have access to yet. It's being finalized, but showing the protection effectiveness of a variety of products. Once again, N95 respirators, FFP2s are at the top, but there's a variety of products that have some protective effect, ranging from anywhere like 30 to 60 to 70%. That's not a negligible protection factor. And so I think we are likely to see that turn into a range of products that might be more helpful in healthcare. Perhaps a hybrid mask design. Whatever we end up with, I think that there is, in addition to the availability issue, an importance in ensuring sustainability. It's always very frustrating in a healthcare system to implement a new device or a new practice only to have it disappear because it's not sustainable. In addition, acceptability and adherence are closely tied factors. As much as I agree that there are reusable devices like elastomeric respirators, those things are limited by their acceptability by the user. It's one thing if you feel your life is truly at risk. I saw a lot of people willing to use those devices when there was fear related to Ebola. But for routine use, and I think it's important that whatever we choose to use be part of our routine. If we can find a routinely used device that does a good job of filtering, a good job of blocking secretions in both directions, and is also comfortable and easy to wear, I think that's going to create acceptability that is directly tied to adherence. The adherence piece at the end of the day is key to the success of any kind of PPE. If people are inconsistent in use, we don't see good effects. And then lastly, implementation of infection control is something that I think is also due for some rethinking. We've talked a little bit about the fact that much of what we do has to be done in packages. And when we think about those combined interventions, I also think about how we attach them to our work. Right now with transmission-based practices, we tend to identify a diagnosis or a suspected diagnosis and recommend certain practices in response. I wonder whether we might not be thinking in the future about other ways of implementation, for example, activity-based precautions. Here you can think of something like triage activities. We might be thinking about how we protect individuals performing triage functions on a routine basis. When you think back to the early slide I showed about all of the risks related to asymptomatic or pre-symptomatic transmission, a syndromic approach to protecting somebody at the very front door of a facility may not be as effective as a routine approach based on the activity itself. We're thinking about something similar in nursing homes where contact precautions can be very challenging to implement, even stigmatizing to the residents. And instead of saying this person has this disease or carries this pathogen, therefore we're going to use contact precautions, we're looking at things like enhanced barrier precautions, where we say anyone bathing a resident or changing a urine bag must always use a gown and gloves. That changes the approach significantly. It makes it, in some senses, much easier to adhere to and much easier to systematize. And that may be the sort of approach that we start to think about going forward. Suffice it to say that we're not done by any stretch of the imagination. There's a lot more work to do related to infection control practices, and part of that is the ongoing evolution of PPE. So with that, thank you everybody for your kind attention. It's been a pleasure joining you.
Thank you. Thank you, Dr. Bell, for this excellent review. Now we are moving to South Africa with the last but not the least speaker, Dr. Joana Darcy Silva. Dr. Silva is infectious disease specialist at Howden, a tertiary care hospital dedicated in the treatment of COVID-19, and she's professor of medicine at the University Center of Brasilia, Brazil. And she will talk about the COVID-19 in South Africa. Please, Dr. Silva.
Good afternoon. I'm Joana Darcy, and thank you for inviting me for this conference. And I will talk about coronavirus in South America. Let's go. This first slide, we see the global situation, epidemic curve. It's very interesting because America represents almost half of the cases of infections and deaths in the world. This is in October 21. Here, in these cases, we can see America, specifically South America here. And I want to show you that each country, each city here, they has some specific situation, unique situation, despite the similarities. For example, we can see different points in the map, yellow ones and white ones, and this is like a desert oasis, because here, for example, is Uruguay. And Uruguay is in between Brazil and Argentina. And they managed to control the pandemic. It's very, very important. On the other hand, we can see here other countries like Brazil, Argentina, Colombia, Mexico. They accumulated a high numbers of cases and deaths. Here we can see red places, Brazil, accumulate high deaths. And but when we check the fatality rates, we can see that Brazil is not Brazil is not in the first place. Here we can see Mexico and Peru and Ecuador, high fatality rate. So maybe in Brazil, we are good and take care of several ill patients, maybe. And these other countries, it's very difficult to find health service, and they have different problems to control and to take care of these poor people. Okay. So continue. Here we can see the distribution by country, and it's very similar that I talk in the previous slides, because here we can see that Brazil have many cases, and for sure, undoubtedly, Brazil have many deaths too in the first place, about deaths and cases. But when we compare the population, the incidence, what can we talking about Aruba, French Guiana? Because Brazil just descends several steps here, appear here. And when we're talking about fatality rates, Brazil didn't appear. So we are not so bad, huh? Countries with the highest numbers of cases, of course, we are here. After United States, after India, we can find Brazil. Brazil impresses by presenting many cases. Here it's better to see because we can compare with another countries and continents. United States first one, India, and after Brazil. Brazil with more than 5 million cases. In this slide, the future scenario is complex for us, because how will be the second wave in America? Wow, the question for $1 million, because America failed to control the cases, despite the current reduction now. Because here, in this graph, it's important to check this, because we have intensive and long exposure. And this is the million of opportunities for the virus change too. And let's see what's happened in the few days. And here, it's better to see the waves. For example, in Europe, it's very easy to see the first wave and the second wave. And in America Latina, I can't see the waves. Let's see in the few days and months what's happened. And each country tried to conduce the different form, and they try to control the pandemic. For example, Argentina at the beginning, they tried to be very strict lockdown, and in the beginning, they are okay. But after that, a lot of cases. In Brazil, similar, not lockdown, of course. Brazil, not like Argentina, but in Brazil, we fluctuated, and we have always a big exposure, just like in other countries, but less than Brazil. And there is a particular countries that we need to take care about neighbors, because sometimes, just like occur in Colombia, because Venezuela is which on the border. So it's very difficult to internal control and border control. This is worst if your neighbor is very attractive. So take care about this. It can be dangerous. And here we need to find a way to reduce the numbers of infected. And what are the numbers out of Latin America? We are in the top 10 in the cases numbers, because not only Brazil, but different countries like Mexico, Argentina, Colombia. So our situation is very complex, and we need to think about this and to looking for other strategies to control the virus. I hope for a vaccine, and I hope this came very soon. And how much testing has been done? Here, unfortunately, we were unable to do many tests. And there is another problem. It's about the low quality tests. Sometimes we use serologic tests, and this is not good. So why we need to be carefully to analyze dates from South America. Another relevant problem is about fragile population, such as an Indians. This is an extremely sad situation. That population can disappear. We can find many deaths in small tribals. When I saw Mexico here, I'm shocked because it's very high numbers, and it's not good. And the worst may come. It's not the only problem in America. We have another problem. It's very big problems that can come if we can control this situation. So, can you imagine this? Some epidemic disease can join to COVID? Oh, it's terrible, huh? Because usually here at the beginning of the year, we can cross some epidemics like dengue, red one here, and influenza. But now, can we imagine it with coronavirus and dengue, Zika, chikungunya, yellow fever, Mayaro, and all the tropical disease? Yeah, I don't want to think too much about this. And here, and last year, when coronavirus started, when the numbers start to grow up like this, the number of dengue cases start to reduce. And this is why some people start to think that COVID protects against dengue. Maybe it's not true. It's just low notification. We need to check this number, but in next month they're going to check this because dengue start here. Let's continue. And it's important to think about dengue and COVID. It's important to think about cross-infection because in this disease, a clinical and laboratory are very similar, and sometimes we are very confused about this co-infection. And the patient, the evolution, maybe it's worst, and it's a big problem too. And for example, in this co-infection, it's common to see false positives for a diagnosis. Sometimes dengue and COVID, it's negative. And in 20% tests, we can find a false positive. This is complicated for us. Another point is when people start to receive, for example, some treatments like convalescent plasma therapy that now we use in the hospital for research, it's a problem if the donors who had the red dengue, because for the patient that's going to receive this plasma, second exposure to dengue leads to severe cases, hemorrhagic disease, and more complicated. Okay, now we're going to talk about research in the world on COVID. We have almost 2,000 studies on treatment and several underdeveloped in America. It's a challenge and a dilemma too, because here we have conflicts about treatment. Here, because sometimes they don't know what is the truth. Communication network and truth, it's complex. And there is different opinions. Everyone in this moment is like an expert in coronavirus. And people just say, who speaks the truth? Who speaks the truth? Scientists, politicians, YouTubers. Yeah, YouTubers is they are famous, huh? And religions. They don't know. They don't know what to do. And this makes a space for fantastic treatments like this. For example, in Ecuador, they try to use vitamin C and seawater injections to treat COVID. In Venezuela, like in Brazil, they use some kind of cocktail of generic drugs and with lemongrass and ginger and some drops of chlorine dioxide antiseptic. This last one, wow, it's a very complex because in Bolivia, they don't need scientific evidence. Just the parliament accepted this, and everybody there start to use chloroquine dioxide. And here in Brazil, we try to do some research about this in the hospital, but when they check that it's very toxic, we didn't. But the patient, they took everything. And when they come for the hospital, sometimes I'm just asked, what did you took for COVID? And they say, I used the protocol. And I said, which protocol? And sometimes in this protocol, they use everything, all this medication together, azithromycin, ivermectin, hydroxychloroquine, nitazoxanide, chlorine dioxide, and corticoids. It's a mess. And sometimes I can't express myself. I'm just check what can I do for the patient. And here, there is another problem too, is when we speak about politics decision and scientific, and science and politics. And the health professionals sometimes stay here, just in the middle. And it's not good because it's difficult to manage this situation because sometimes it is just a big deal. It's not science, it's just a big deal. Okay, let me talk about my hospital. I work in this region in middle of Brazil in reference of COVID hospital in capital. This is a generic hospital with 300 beds. And in last month, they removed all the specialized and we just saw patients with COVID, with coronavirus. And here is the research that we try to improve there. This one, drugs chloroquine, we didn't, and chlorine dioxide, we didn't too. But this slide is very complicated. Huh? Let me to do this more easy. Here. Now we check 5 treatments. One with heparin and tocilizumab, another with convalescent plasma, and 2 antivirus. And nitazoxanide, we finished these. And the result, not so good. And another study is about individual protection equipment like mask and face shield, and we're looking for new technology that use nanoparticles to do this more safely for the health professional. Another study is about morbid mortality and natural history, COVID natural history. And the last one is a project with WHO about global clinical platform. This is interesting. Let's see, because some hospitals are very, very jealous to show our databases. That's all. Thank you for your attention. Wish science will contribute to saving maskless world. And what can I say? I hope to see you in the future without masks. Bye-bye.
Oh, who is the person with me on IPC?
Thank you, dear Dr. Silva, for this comprehensive review. Dear colleagues, that brings us to
no, I didn't say it's you. It's not you now.
Okay. That brings us to the end of our meeting. And now I'd like to give the word to Dr. Dryden to close up. Matthew.
Thank you, Serhat. We've gone on a long time. It's been a very long session, but an absolutely fascinating record of how we're all dealing with COVID across the globe. So can I thank all the several hundred participants that we had on occasions very much for their attendance. Can I thank ISAC and the Academy of ISAC for setting up this first symposium, and may we have several more. Thanks to my co-moderator Serhat, and thanks to the company for providing all the support to this symposium. Have a good day, everybody, and stay safe. Thank you.
Okay. See you all in the other meetings. Bye-bye.